researchers, postdoc fellows, postgraduate students, and other researchers. Today is another beautiful day. It's the second day and the final day of the first Rwanda Science, Technology, and Innovation Conference. I believe for those who were here yesterday, you can testify that we had a very fruitful day. If you remember, we started with a welcome and opening remarks, which were given by the chair of our organizing committee, our lovely sister, but also our NCST executive secretary, as well as Honorable Minister of Health, who went through the Rwandan's response to COVID-19 pandemic, and he provided the future direction. If you remember, yesterday, after the welcome and opening remarks, we had the opportunity of hearing oral presentations as well as keynote speakers on two themes: public health and COVID-19 management, as well as building resilience to public health crisis and the COVID-19 pandemic. So today, we will once again have oral presentations as well as keynote addresses on two themes. So the first is the African response to COVID-19 pandemic and predicting as well as monitoring the impact of pandemic. And the other theme will be vaccines and the future of developing countries, the COVID-19 pandemic crisis. I am the chair and the moderator for the session, the fourth session. For those who have this nice, well-made booklet, page number 28. So my name is there. Let me remind you that during the health break, we will continue having the poster presentations and the exhibitions. So please make sure that you visit and hear a lot from the exhibitors, but as well as the poster presenters. Dear participants, if you remember yesterday, after the presentation, especially oral presentation, we had questions. Okay, the first presenter presented, and then we have questions. But today, we have a slightly modified method. So after our keynote address by our Prof. Cloud, there will be some questions to him, I believe, and more, because he is from RBC. And then we will have two presentations. After the two presentations, then we will ask the presenters simultaneously. That means after the first presenter, Dr. Christopher, sorry, I'm not good in pronouncing the names. Dr. Christopher, after his presentation, we won't ask him questions, you just reserve, write it somewhere because of the time, and then we will allow Dr. Reed to come, present, and then together we will ask them questions. Now, let's start, and if you have questions, the organizers are here, feel free to ask them. Let's start with the keynote address by Professor Claude Mambo Muvunyi, who is the Director General of Rwanda Biomedical Center. For your information, he holds a degree in general medicine from the University of Rwanda, but also did his master's at University of Manchester and also the PhD in Belgium. His research interests includes evaluation of diagnostic methods for infectious diseases and operational research on diagnostic for infectious diseases. He has more than 10 years of technical, managerial, and strategic experiences. He served as a senior regional laboratory advisor at International Center for AIDS Care and Treatment Program. In addition to that, he served as the head of National reference laboratory, and the director of microbiology unity for AIDS vaccine clinical and visibility research at Project San Francisco. Please, distinguished guests, let us welcome Prof. Claude Mambo Mvunyi.
Good morning, everyone. Good morning. I think today probably there are a few participants who are still coming because probably yesterday was a very busy and interesting day. But I think let's start today. So for this presentation, there are two main sections. So one is that I'm going to give a brief presentation of our response to COVID. And it was very difficult for me to really be able to summarize all the efforts and interventions that RBC and Rwandan country put together to really plan and also respond to this COVID. But first of all, I'd like to thank the Executive Secretary of the National Council for Science and Technology, and also the organizing committee to provide to me this opportunity to present to this conference, and also to present on the few highlights of RBC response to the COVID. And then for this, I think RBC had some privilege to work with other sectors. So it was not only the effort of RBC, but also other sectors like national police, the local government, and in addition to that, also we had the opportunity to be backed by His Excellency President Kagame from the beginning of this response until today. And our response has been very robust, rapid, and also very targeted to really contain the infections. So next, please. So I'll briefly take you through the overview of the COVID-19 response and epidemiological situations. And then I'll also cover some of the innovative digital solutions that we use in our response. And last but not least, I will also present on a few lessons that we could get from this period of pandemics, and also what could be the next, the way forward in terms of learning how to live with the viruses. Next, please. So I think, so if you remember very well, at the beginning of this pandemic, if I can recall very well, it was around January, where Rwanda had also to be ready, and we had opportunity to leverage on some of our system. And first of all, with our country being at risk of Ebola, not because we have a case in Rwanda, but because neighboring countries have some cases, we had already some system in place, and I can mention some few of them. The first one that we had a very good established EOCs at some of our provinces that was very ready to be used. And we also have had a very strong system and national staff that were already at the border, at the airports, knowing that they can also be, can also screen for temperature, for example, for Ebola. So the system was already very there. And we can also mention that we really leverage on the existing testing capacity that we had at the National Reference Lab. That was actually one of the only lab that had that capacity, where we used to do testing for influenza. So influenza is another virus that is similar to COVID-19, and the testing methodology, the testing modality is also similar. So we really leverage on that infrastructure, human resource, which was very well trained to test for influenza. And we also had already a team, a response team for Ebola, which was already established there. So we had only to do some refresher training for them to really be ready to respond to COVID. And this response team with well-trained IPC staff, and also I remember that the testing also began I think before even we had the first case, because we had some samples from influenza that were coming from our surveillance site. And I remember also, if you recall very well, we had also some events which were planned at that time, and the lab had to really bring some support from Germany to come with the tests and train the staff, but also a test for some samples. So this was really very important for us to respond to the COVID at the beginning. Next, please. So again, this pandemic again found us already with a good and very strong health system made of a very good primary health care, where we had enough staff at all the levels, and also at all its facilities, we had also existing data system that was used for other diseases, and the supply chain was already well established in terms of really getting supplies in country. And also for case management, we had to really identify very quickly some sites that could be a site to manage cases for COVID. And this is something that really allow us to identify needs for capacity building for our staff, but also to have those refresher training for our staff. So again, next to this, yes. So again, for measures, I think in early March also, we had already a task force. So we established a task force, and also the task force was really called to develop guidelines, which was issued on 6th of March, even before we had the first case. And those guidelines were very clear in terms of putting in place some measures like hand washing stations at all public places, and also procurements, and also how to use masks, and also education around physical distancing, and also testing system to be at everywhere. So if you can see in these slides, at the beginning of 2020, we had only one lab which was able to do testing for COVID. And later on, we scaled the testing to other facilities. And with the availability of the rapid antigen tests, we're able to really avail and make very antigen tests that could be accessible to everyone at all health facilities. So we can see in 2021, we had at least most of the facilities be able to test and also to manage COVID. I will not go into details about the management of cases. We had some facilities and also hotels were there also were availed to really manage cases at the beginning. And for the communities, the community was not left out. So we had a very good interventions at the community levels, where we had community health workers who could also use some tablets and the software to screen for COVID and categorize patients into different categories, like low risk for COVID, suspected, where they can be subjected to antigen test at home, at household level. And also, depending on the test, they can also be referred to facility to confirm COVID and also management of COVID. And all these was linked to our existing system like HMIS that could be able to have data at central level. Next, please. So all our actions were guided by the use of routinely collected data to really provide information to anticipate and prepare effectively to respond to challenges that we were faced by COVID. And those data were also used either in forms of discussion at different stakeholders, steering committees, task force, to really also update in terms of measures to be put in controlling the infections. And our interventions were also regularly monitored, in the sense that, as many other countries experienced, we also had 4 waves of COVID, and we just came out recently from our 4th waves due to Omicron. Omicron. Next, please. And we also, in terms of vaccination, so moving from testing to vaccinations, so we had also, between testing and vaccination, we also had some drugs which were available in the country to manage serious cases. We also had our facilities equipped with SICU, able to really take care of serious cases and so on. And in addition, that vaccine, we remember that at the beginning, vaccine was not really accessible in most of the African countries, but Rwanda was among the pioneers to really embrace or to really have a very strong policy on vaccinations. And we use our system, our normal system for childhood vaccinations, which were there, able to acquire some vaccines, like Pfizer vaccines, that required a very strict logistic system in terms of storing the vaccines. So this was very helpful for us to acquire and also deploy vaccine to everywhere. And because of that, we had a very good coverage of vaccinations, as you can see, where we have even distributions of increased coverage of both first and second dose of vaccinations. And as of today, we have around 8 million of Rwandan populations fully vaccinated, so we have 2 vaccines doses. And we have around 3 million of Rwandan population who are the booster, who have been boosted for vaccinations. And we are still continuing to really make sure that we also vaccinate the group of population between 12 to 18 years. And also, we are also negotiating with Pfizer to get also the pediatric formulation for children between 5 and 11. I know that there are many questions, debate about vaccination, but for us, I think we make sure that we are ready with a good coverage, a good immunity to really prevent any severe cases, and also to prevent group of population who are at risk of dying from this COVID. So those who are aged above 65 could be prioritized to get the booster, but also vaccinating other group of populations is also one of the strategies to really protect the vulnerable populations. Next, please. So, so I can say that digitalizations of some of our services was very key to generate unique opportunities to strategically address some challenges associated with COVID and pandemics. And those digital tools allow to communicate reliable information and also support testing and vaccination efforts. And I will just name a few of them. And we have a video, a short video at the end of this presentation that will also provide some additional details on those digital tools. So as you can see in our cascade of detecting, quarantine, all suspect management cases, and also until isolations, we had different tools that we use to really make sure that we really are effective in terms of managing the infection. So we had also a system like USSD numbers where patient could be reached out and provide information, the WhatsApp for within health facilities, and also the passenger locator form that also available to really provide some information for the immigrations at the airports. And at the level of suspect cases, I thought we also use the same thing. And then for the bracelet, we use those bracelets to really monitor if some suspect patient cases are really well adhering to the measures. For the testing, we moved, I will show it later, we moved from paper-based system to also electronic testing management. So that was through the DHS2 that we had, was customized to really get software to really from the testing, giving information, entering the information from the test request, transferring the information from test to the messages, to emails, and so on. So I think we can see that at all of our cascade, we really use innovative digital solutions to facilitate testing. Next, please. So I think you can see some few examples of those digital tools, and we had application the geoinformation technology, so the GPS, to really track and monitor the pandemic spread around Rwanda, and also we use at the beginning also humanoid robots, which was very important in our treatment center, to minimize physical contact at the beginning because there were some fears and people were scared to really get infection. So those robots were very efficient to deliver food and medication to patients in isolation. And so this really minimizes physical contact and also prevent spread of infections. And I also mentioned the DHS2 tools, which was also customized to really provide some data dashboards and also real-time data to really visualize where the problem is, but also help the decision makers to put decision. Next, please. So you can see I was mentioning about the test in the lab. So we moved from the paper-based and manual test management to this DHS system, which has really addressed some of the challenges that are associated with this manual and paper-based. So we have really to reduce the workloads, to really reduce the time also between the sample collections, sample receptions to service to the result dispatch. We also had to really reduce the number of errors in terms of missing informations or errors on manual writing of those informations. Next, please. And our DHS system was also customized to allow giving test SMS message. And when, for example, when you come for testing, you can also get a very short message to tell you that you have been tested for COVID, and also when the result is available, the result could also be delivered through SMS. So this is also another mechanism that we use to really reduce the time from testing to results, and also reduce the time when the patient, for example, can be exposed to cases. And at the same time, also we had also an online portal for COVID results, where we can also put your information in the system online and get the certificate that can be used for any purpose. Next, please. This DHS2 was also customized in addition to get the certificate from the system. You can also send it to the emails. We could also be able to have a dashboard that could tell you the number of the tests done per day, but also to provide the daily report that we give each day on the number of tests done, number of positivities, and also to share data into international system. Next, please. And also the QR code was also possible due to this system where we can also use the QR code at the airport while traveling. Next, please. Again, when it comes to vaccinations also, we leverage our vaccinations interventions on this existing system, those tools, where we have a system which is able to register the vaccinees in terms of their demographic informations, the type of vaccines that they received, and each one has a unique ID linked to the vaccine type and also so on, because you had many type of vaccines. So I think we also have to do that also. So this platform has 3 modules. So there's SMS notifications, online printing of certificates, as you can see for testing also. Next, please. There is a very important other innovative software that was also available, not only to give results, but also for the population to also seek some education materials and any information around COVID to really also minimize those stigma, to also get some messages on how to protect themselves against COVID. So this is a chat bot where there is a live exchange of messages between health providers and also populations. Next. So this, I think, this is the recent, in 2 weeks' time, statistics where we see the high figures of people who have used this system, and also both for vaccination and also test result application. Next, please. Last but not least, let's now summarize our response in terms of key areas. Next, please. We know that, as I was saying, that our response was really, we had the opportunities to leverage on, and one of them, as I mentioned, is the existing infrastructures and the community support, and also multi-sector support from all the sectors around this response. As you can see, even this excellency was there to support the team, the response team, but also taking part into that response so that we can have trust in our leadership. And you also have data, the use of data to always guide our decisions, but also to really facilitate the response. Importantly, we could not do that ourselves because we can be only safe when everyone is safe. So we also rely our response on the local and also global partnership in terms of getting free tests, vaccinations to those COVAX and so on. Next, please. Now, what do we have to do? Because the COVID is still there. We still have new variants. And we need to really learn to live with the viruses. And in our response, I think now we understand that there are 3 areas that we need to focus on. One is the diagnostic resilience. Second is therapeutic resilience, but also vaccine resilience. So we have to have a security, diagnostic security in terms of having enough capacity for testing, but also another important areas where we have invested also is the sequencing, because sequencing is now the only tools that will monitor the emergencies of any new variant so that we can really identify on time those new variants, and so that before it even spreads to the community. And as you can see there, we have also equipped our facilities with very good ICU infrastructures to manage any cases in terms of severity of the disease and so on. And as you can see here on the far right, we have also a new mobile state-of-the-art treatment center where we have anything in those. We have ICU, operating theater, gynecologic delivery rooms, where we can really manage all the cases from now on. So this was really being possible with the support of partners, so that we can have these facilities to really manage our cases. So therapeutic in case management was really one of the things we want to mention. Oxygen, vaccine, cold chain. So in terms of vaccine security, we know that there are some countries now in the negotiation to get the vaccine manufacturer plants in Africa, and Rwanda is among those countries. So we have also taken that seriously, so that we have a production of vaccine here in Rwanda, not only for COVID, but also an opportunity for other vaccines, and for TB and also HIV in the future. And this is one of the solutions to also be prepared for other pandemic or any other diseases. So I think with that, I would like to thank you very much again for the opportunity to provide a brief overview of this response that Rwanda had again to the COVID. So as I mentioned, there's a short video that I would like to display of 5 minutes, if you allow the organizer.
RBC showcase use different strategies that fundamentally involve science and technology. RBC showcase use different strategies that fundamentally involve science and technology.
I'm not sure.
RBC showcase use different strategies that fundamentally.
So anyway, I think there's some issues with the video, but I would request you to go to the exhibition where RBC is. You have those video for more information and details. Thank you very much again, and I'm happy to take some questions and comments if there are any.
So it's the time for questions. Okay, so 1, 2, 3, 4, 5, as I say. You should okay, so this is start.
Thank you so much, Professor. My name is Joseline, and I'm an early researcher in the Center of Excellence in Biodiversity and Natural Resource Management. My question, first of all, I want to thank you for this presentation. I liked the part for the lesson learned. It's really interesting. And my question is about the therapeutic resilience. What are you doing? And I'm wondering if you already have any medicine that you suspect it can be a cure to the COVID-19 or other viruses pandemic. And I also want to know, because there is some rumors that traditional medicine will being used more than other modern medicine in this pandemic. So I'm wondering if there is a plan to screen some traditional medicine, herbs, or using some indigenous knowledge to see if you can have some future modern medicine for pandemics and other diseases.
Okay, thank you, Prof. I think if they can ask all questions, yes.
Thank you very much, Professor, for a good presentation. My question is about the mobile hospital. You talked about mobile hospital. I would like to know more about it. Where is it located, and in which case it is moved from one place to another? And yeah, it's more about it. Thank you.
Thank you.
Thank you so much. I'm Jean-Pierre Muhirwa from University of Rwanda. My question is about vaccines. Some vaccines are produced from human DNA sequence, and can this not perturb the human DNA? Is there any scientific research that says about that? Thank you.
Thank you.
Thank you, Prof, for a nice presentation. I'm called Dennis Ndanguza from University of Rwanda. My question goes to the training of the staff. So I would like if there is any plan also to link RBC with the national researchers. You know, many researchers are doing research on COVID, but they have really limited knowledge on COVID. So do you plan to train researchers, or regularly having a workshop or meeting with researchers so that they may be able to conduct research on a topic they master? Thank you.
Thank you. Next.
All right. Thank you very much, Professor. Your presentation has been so informative and excellent. Globally, most challenges that come to our communities have been solved by the issue of digital solution. Now, you find that we have issues concerning what we call digital divide, where the local man at the grassroots is excluded from access to some of this digital solution. Now, I was wondering, in case of some kind of future occurrence of pandemics and any other challenges in our communities, how do the health sector plan to solve this issue of digital divide? For example, I'm very happy because I see that you've translated some of the results in the local language. That helps the local man who is not educated to read and understand that these are some of the information concerning COVID. But still, you find that there are a lot of challenges with the digital solution that we use in our communities. Now, from the health perspective, what do you plan as the RBC? Thank you very much for your great job.
Okay, so we still have more questions. Maybe this should be the last one. And then since Prof is here, let's go to Muse first.
Thank you very much, Professor, for your good presentation. My question is directed to the various higher education of learning. As far as RBC is concerned, we understand that you have very good data, and we could request that if there is a way we can allow universities to reach the data, specifically which you have, that we enable our students in the universities to utilize the data on doing further research, and specifically to come up with other discoveries. Number two is that if there is a way, the RBC will be encouraging specifically high schools or rather secondary schools to also come up with the science congresses to develop specific drugs. Of course, other countries have got such like a means whereby they enable the students to also come up to discover drugs, but they should have some link between the data you have. Sometimes you can also have science congresses which are informative to the universities. If you have such like a plan. Thank you very much.
Yeah, so I knew there would be many questions. So please reserve your questions. We will ask you, Prof, later. Prof, can you respond to the question that have been asked? Thank you.
Thank you very much for those great questions and requests, but also some comments. I'm going to respond to a few of them, but if there's any other additional comment, I think we can still continue the discussion. So the first question around therapeutic resilience or therapeutic security, I think you're right that at African level, we do have many speculation in terms of some activities or medicinal plants that we have in Rwanda or in Western Africa. But again, we haven't really benefited or really taken this opportunity to go further and probably analyze and know exactly if those components of that plant can be efficient on viruses. On viruses, we know that we have many plants that are known to have
in 2016, Rwanda recorded an upsurge of malaria, and we had registered around 5 million malaria cases nationwide. From 2016, it is when we put in place key malaria control interventions
to do some experiments in most of the African countries. And I think there are now some efforts. I know that there are some traditional medicine in DRC, but again, there were speculations, and it was not really. We could not really know exactly if those drugs are effective. So we need to build the capacity for the lab to do experiments in pre-lab. So a level or biosafety level 4 to contain those viruses in the lab, and then understand very well in vitro the effect of those components to the viruses. But again, when it comes to that, also after that, we need also to have system regulations. And in Rwanda, for example, we are now building the capacity of FDA, the Rwanda Food and Drug Administrations, so that they can also regulate once the product is able to be put on the market. So there is now some mobilizations of effort with the support of African CDC, African Union, to really now build those capacities so that we can really be prepared for other pandemics. And the deployment of vaccine manufacturing plants through the collaboration with BioNTech, for example, is another opportunity that we are going to leverage on to really have those pharmaceutical hubs in Africa, so that we can really build the capacity of our staff, researchers, to be able to drive those initiatives in terms of really making sure that we have also pharmaceutical companies from Rwanda be able to achieve or to get products from an experiment to the market. In terms of other drugs that are known to have effect on the COVID, we have some antivirals that we use in Rwanda, and also we are still continuing to use those antivirals. So with combination of antiviral drugs, but also with antibiotics, and also other products that can also be able to manage cases when they are there. But again, in Africa also, we need to have a strong clinical trials capacity, so that those products, once they come from the lab, they have to be also trialed. And we need to really use the opportunity to really convince or advocate for the policymakers to allow all those things to happen. And this is something we need to continue to advocate for that, and I think this could be possible. to screen those components. The second question around mobile hospital. So the mobile hospital is located in Nyamata, not far from the Kigali. It's around 25 minutes driving to that area. It's also located next to the hospital, next to the provincial or district hospital, where we think that this mobile can be integrated in that hospital. But in the sense that we want to move also this mobile to another place, it can take you a day, for example, because those are containers. They can be moved from one place to another place. But you need to just prepare the site where the mobile container need to be implanted. So I think it's possible to move it from one place to another place. So I think this is possible with the mobile hospital. And as I mentioned before, the mobile hospital has everything in one. So we have ICUs, hospital beds, theater when we have a case to be operated. So everything is in that mobile clinic. Vaccine based on those mRNA and also on the human DNA. I think there's no risk as of now, but we don't know probably what will happen in the long term. But as far as the product development, we understand that those are only a copy of the genetic materials that we think may not be a problem for human genomic. But we have in the room, Prof, maybe he can also comment on that maybe after my presentation. So I think I don't expect there's any risk for that, but anyway, we don't know yet what can happen in the future, but we still continue to monitor. That's why those pharmaceutical companies need to monitor post-vaccinations effect, but we don't know yet until when we need to monitor the post-vaccinations adverse effect. For Rwanda, we have a system to monitor the adverse event, but it's not really, it cannot go on more than 1 year, but I think there's a system to monitor at international level. Training of staff, I agree with this request, and we are going to take it into consideration. For this, I think RBC, and I'll answer this question with the other question with on higher education learning with RBC. So I think at RBC we have already started these collaborations, and actually 2 weeks ago we received a request from the University of Rwanda to use one of our staff, because we have really skilled staff who can support the teaching, but also the research with collaboration with those universities. So I think what we are going to really make sure that we promote the research at RBC, so that we first of all, we have to really improve our data, because there's a lot to do on data, we have good data, but also to build the capacity of our staff also to do research. And also, you know that we were discussing with the executive secretary. We cannot do research alone. We need collaborations in terms of mobilizing funds for research, and I'm glad that the NCST is doing that for us. But again, we need to also do something around policies that can also allow the environment to motivate people to do research. And we can do that also with the collaboration with the University of Rwanda, but also other higher learning institutions. So we have good data, good researcher, and also this is one of the platforms also which could also bring us together. This type of conference, for example, is one of the way to bring people together, but also to promote the research. And there's another research, there's another conference that we are preparing also with RBC and also the University of Rwanda on the topic around, similar to this topic. Maybe it's going to happen in April or May. It's also another evidence of collaboration. So we are working with the University of Rwanda to have that. I think we have launched last 2 days ago the call for abstracts. So again, probably at the end of this conference, we'll have the opportunity to also distribute some flyers for people who are here to also apply or to send abstract for that research. So those are the type of collaborations. Digitalization is how are you assuring that the community have also access to digitalization? So I've named some few of the tools. So since we can't, since the access to the Android system might not be a problem, literacy might be a problem, but we are working to make sure that we have some system that's, for example, allow the community to be in touch with the healthcare providers in terms of those chat box, for example. Chat box today is used for COVID, but we are planning to also integrate all other diseases for that, so that the community can get information on certain disease. They can also ask questions to really get some education materials and information through these tools. And for the COVID also, we had the USSD code that they can also use to really make sure that we also put this technology close to the communities. In Rwanda, we have also health worker communities where the plan from now is to digitalize some of the activities. So we are going to procure some tablets for them so that they can really be able to really leave the manual system, paper-based manuals, so that they can really enter the information into the tablets while in the household, in the communities, so that we can get information from the central level. So again, there are a lot of effort and initiative, not only from the health sector, but also using our Ministry of ICT and also RISA to make sure that also those communities are not left out of the effort. So I think those were the questions that I had to respond. If you allow, moderator, I can give, if you have 1 minute for Professor to because he had also had hand raised for question, if allowed. Yeah.
Yeah. Thank you very much for a wonderful summary of the response by Rwanda to the pandemic. Also, a really great response to the wonderful questions from the audience. I wanted Rwanda finds itself in a unique position compared to many other countries around the world, and that is it's landlocked, so you have really very few points of entry. I was wondering, in the future, do you have a strategy or a architecture that you plan to use for not only looking at COVID-19, but also future pathogens that may represent a security risk?
Thank you very much, Prof. I think, yes, as I mentioned before, this was not the only outbreak or pandemic that we had in the region. So we had Ebola, and Ebola is in DRC, Uganda. So there's a regional effort in terms of capacity building for response team, but also cross-border mechanism on really on how to early detection of those outbreaks, but also the communications to the population. So I think there's a lot of effort at the cross-border in the region where we have a platform where we share information, data, and recently, I think 2 weeks ago, we had the case of yellow fever, for example, in Uganda, and the communication was very quickly disseminated to Rwanda, and the team was really ready to do some interventions, and people were ready to do something in case there is a pandemic. Today in Rwanda, we also have some Rift Valley cases in animals, and we are suspecting some cases human in that region of Nyagatare. And actually today we are working with cities, for example, to bring kits, because we have the facility for testing, but we need some reagents so that we can test and confirm those cases. But I know that even to prevent or to put a system of surveillance is also very important. So we have satellite sites that are there to survey. So we have also many projects around regions targeting specific disease of high risk of epidemic in the regions where we do surveillance of cases. In this region, we have what we call the IDSR, a system, a software that also reports cases from the community to the central levels, where we have teams that are there, not only in the health sector, but also in the other sector of agriculture and also veterinary sector, where we have a one health approach to really detect in time those new pandemic. But again, as I mentioned, we still have some gaps in terms of system to monitor, to do surveillance, for example, on wastewater, for example, and also capacity diagnosis. We really have a regular system for monitoring any cases that can happen. So I think we continue to build a system. And one thing that I've mentioned with the COVID pandemic, we have had the opportunity to also build the capacity for sequencing. And with the sequencing, we can really develop a data system where we can know exactly the data at the genomic level of a pathogen, for example, so that we can monitor everything which is new in our region, so that we are ready to contain any new cases when it occurs. So the capacity is not only for COVID, but also for other diseases, other pathogens. So thank you very much.
Okay, thank you very much, Maureen.
Technology in response to COVID-19, different strategies that fundamentally involve science and technology in response to COVID-19 pandemics. We also apply the use of GPS tracking watches for COVID-19 patients and contacts. And last but not least, the GPS tracking of truck entering Rwanda was also one of our innovative approaches to monitor truck drivers from the border to their destinations.
Before we brought the system in place, it was hard for the citizens to know their COVID status. Another part of impact was on travelers, but where the borders were opened and the airport was open, there was a need of having a way of passengers to print to have their certificate without lining up at the lab. So we managed to integrate with the primary system, which was the COVID system, the HMS1, to ensure that the portals are available to the passengers, portals are available to the population to be able to print their certificates. We also integrated with USSD 114, where you can be able to press *114, then hash, then from there you continue step by step, and from the 114 you are able to retrieve your information through the API.
One in particular has to do with the data science room, as well as the Rwanda Health Analytics platform, which have been established by the RBC, the Ministry of Health, and our partners. So what we've been able to do with the Rwanda Health Analytics platform, which is at the core of our advanced analytics, is to be able to not only that, but also establishing a data science room where we're able to display the data from the healthcare facilities.
As we respond to the emergencies, also considering COVID-19 as an outbreak we are dealing with currently, National Reference Laboratory has built the capacity in next generation sequencing so that we can be able to do the surveillance or the genomic surveillance of SARS-CoV-2 or COVID-19 virus across the country. Currently, we have run more than 800 sequences that we have been able to publish to GSIDE, which is an open source for information for sequences of different disease outbreaks.
But I also want to highlight other research projects that are being run, led by the Rwanda Biomedical Center. One in particular is using digital tools and antigen rapid diagnostic tests to basically provide or leveraging community health workers network in the country to be able to provide a COVID-19 test right at the household level. It's important for many reasons because, as you know, we are always looking forward to basically increasing access to diagnostics, especially in the middle of the current pandemic of COVID-19. So with this project in particular, we're able to leverage existing community health workers network using digital tools as well as the rapid diagnostic test, and ensuring that we have these tests done at household level, which is the last mile.
Since the identification of the first case, the country opted to rely on evidence and data to guide interventions. COVID surveillance system was anchored in all health facilities and utilized simple electronic tools that share data on a daily basis. This enabled the country to monitor progress made for every established intervention. Other innovative tools that were used during the fight on COVID pandemic range from the use of toll-free hotline, use of drones for information dissemination, and use of robots for patients monitoring in hospitals. Lesson learned from COVID pandemic that will help us in preparing for the future pandemic. There's always need to leverage on existing structures. Also, there's a need also to adapt response based on specific challenges. The use of data is main key pillar, should also be put in place to guide decisions. There's a need always to strengthen the decentralized structures and also to ensure comprehensive response at all levels.
To achieve that, RBC works closely with national and international collaborators to efficiently save the life of Rwandan. And as we can say, everyone's actions was really needed to reach the good health and well-being of Rwanda.
Okay, thank you very much. Next presenter, please.
I'm going to present the preliminary results of the study one of the studies that has been funded by NCST. The research team reports no conflicts of interest. Next. That's the outline I'll be using in my presentation. Next. So as you know, this pandemic has affected various sectors, including health sector, and surgical services was also included globally and locally. In certain regions, we have seen that some elective cases were postponed and only managing emergency cases. And some of the patients were not even attending the health facility because they were either fearing to get contact, get the virus, or the hospitals wanted to prioritize resources so that they can put effort mainly to combat this pandemic. In Rwanda, the access in surgical cases is limited with sufficient surgical capacity, and we have a longer limit surgical needs. comparing the surgical volumes as well as the workforce available. We have said that during this pandemic, this burden has worsened. The aim of the study was to assess the impact of COVID-19 pandemic surgical access in Rwanda. The objective was to find the volume of surgeries that have been performed. We took 1 year before COVID and 1 year during COVID, and we compared the data during those 2 periods. We looked at the patient visiting hospitals with outpatient consultations. We determined the cases managed based on different surgical specialties, and also we did focus group discussions on surgical healthcare providers and community health workers to know what was the challenges they met in terms of surgical care delivery during the COVID-19. And this is to develop a toolkit that can be used by Rwanda surgical community during the next pandemic, so that patients who are in need of surgical care cannot miss that service in case they are dealing with the pandemic. This was a centric nationwide cross-sectional study that we conducted at the 22 hospitals, at 4 national teaching hospitals, 3 referral hospitals, 4 provincial hospitals, and 2 hospitals per province. So we, as I said, we took 1 year before complete pandemic, and data also were collected during the pandemic. So we collected data on the number of surgeries performed, the number of surgical outpatient by different specialties, and also we gathered quantitative data on the challenges encountered during that period. We compared data before and during the pandemic. We considered a regression model to assess the impact of COVID-19 year and the lockdown, total country lockdown, and district lockdown on surgeries performed. As the result, there was a decrease of surgeries performed comparing the COVID year versus year before COVID. There was a decrease of around 1.8%. Next. In terms of emergencies, the next slide is showing emergency versus electives. During the pandemic, there was a decrease because we had around 40.6% versus 43% before COVID. There was around 3.6 decrease, especially on emergency cases managed during COVID. As far as the specialty is concerned, there was in general the decrease both elective and emergency comparing different surgical specialty, but the main specialty that was affected was orthopedics, general surgery, and gynecology. Next. If you look at all the different surgical specialties, there was a decrease. However, in the maxillofacial surgery and cardiothoracic, the emergencies were a little bit high compared to the year prior to the pandemic. This would be likely some cases that were likely misrecorded in this during the data recording. Next. If you look at the outpatient services, in general, during the COVID-19 year, there has been a decrease, but when you look at the total country lockdown, there was a decrease of numbers, but in the digital lockdown, there was really no decrease. And data for outpatient were calculated on a weekly basis and also comparing each surgical specialty. Next. And they said, but if you look at obstetrics and gynecology, and also you look at cardiac surgery, there was really, the studies were almost the same, there was no big difference. When we look at the surgical cases managed during the COVID-19 lockdowns, we look at the top 5 conditions, and on the left side it's a country lockdown, the other side is other time when we were not in total country lockdown. We found that the obstetrics were among the top cases managed in both periods, followed by Lode and others. Next. This is also to compare how the cases increased, varied according to district lockdown versus other period time without lockdowns. And I've seen, you can see that the obstetric cesarean sections were the most performed procedures, and also the abdominal hernias in general surgery. Next. So when you look at the outcome, we have looked at outcomes we have compared how the ICU admissions access during the country lockdown. There was no big difference. However, there was an increased odds of being admitted in ICU during the total country lockdown. Next. And when you look at district lockdown, there was no difference. However, there was a variation of around 0.1%. When you look at the status at discharge, defined as whether the patient dead or the patient has been transferred to other level or discharged improved at home, we have seen that the majority of patients were discharged alive, and there was no difference in terms of being in country total lockdown or district lockdown. Next. Next. If you look at the hospital length of stay, we have seen that the median, you can see it's almost the same. We have the intercultural range ranging between 2 to 4 days. There was a minimal variation of 1 to 2 days in general. Comparing whether we are in COVID-19 here, whether we are in total country lockdown or district lockdown. We have also conducted the focus group discussions to surgical care providers to know challenges they have met, especially during the total country lockdown. What we have seen is that some patients are missing appointments due to failure to reach health facilities, which was really understandable. There was also a shortage of hospital staff because some of the hospital staff were required to other duties, mainly to deal with this pandemic. There was also an availability of beds due to prioritization for COVID-19 patients. There are also other, which is around 17.9%. Here, in others, there are some surgical care providers who were reporting that they have not been trained to manage the patient with surgical condition who is infected with COVID or suspected to have COVID. And some of even the surgeons, they were not really trained to deal with that. This is the summary of the statistics I was talking. This is a model we made, and this model we compared the data versus COVID-19 period, country lockdown or district lockdown. And the variables, we have controlled the variables and based on the hospital type as well as case specialty. And we will see they are inpatients and others. So in general, the impact this showed that we already know we have animate surgical needs. And this pandemic has increased this animate. Therefore, we need as a society, surgical society, to be ready and also bring strategies to start giving care to these patients that are still waiting, who have been increased, where the list has been increased, we need to bring strategies. One of the strategies we are thinking is to have a regular outreach that will be done by the surgical society. As you may know, majority of surgeons we have in Rwanda now currently we have around 108 surgeons, all specialties combined, and 80% of those surgeons they are in teaching hospitals. So and those patients they are in the country outside Kigali. So one of the strategies that this information will help us as a surgical community to create solutions so that we can go down and reach those populations and give service to them. Number two is that we also need to come out with a toolkit that can help us deal with other pandemic. Once we have another pandemic, how can we manage surgical cases during the pandemic so that patients don't delay to consult? Because some of those patients delay to consult, especially those with malignant conditions, and when they present rate, the outcome is worse. So we need to really see how, as a society, we can come down and bring solutions, give service to those waiting for it, and also make sure we contribute in the building the health system, especially the surgical care service in our society. And this data suggests that there are recommendable resilience of surgery system, especially outpatient services. I cannot end this presentation without thanking the government of Rwanda and the NCST through the funding they have given us to conduct this study. I also thank the collaborators, RBC, University of Global Equity, University of Rwanda, the Global Surgery Hub of Rwanda that are collaborating to conduct this study. And also I thank medical students who contributed in data collection and also learning how they can be involved in research. Thank you.
Thank you very much. So as I said, just your questions to ask at the end. I got a message, someone asked the RBC director to respond to the question about the data. So you can ask him at the end about the data. Thank you. Next presentation, please. Compartmental modeling of the transition for continuing Rwanda. Dr. Rich.
I'm from the Department of Mathematics, College of Science and Technology at the University of Rwanda. I'm going to present about compartmental mathematical modeling of dynamic transmissions of COVID-19 in Rwanda. Slides, please. So this is a joint work with Professor Ntaganda Jean-Marie, Dr. Muhirwa Jean-Pierre, all from the Department of Mathematics at the University of Rwanda, Dr. Betty Kivumbi Nanyonga from Makerere University, Dr. Nio Mungiro Jafet from the National Council of Science and Technology, and a medical doctor from the Internal Medicine Department, Dr. Ntaganda Eric at CHPK. So we recognize the research grant from NCST, our host institution, and RBC that provided us with data. So the outline of my talk, I briefly talk about the background of COVID-19 in Rwanda and our model, the mathematical model that we have developed for studying the dynamic of COVID-19 in Rwanda and the resulting equations. After that, since a model is made by compartments, so since our model is made by compartments, those compartments are connected by parameters. Some are known, those are not known. So we used we make a parameter estimation, and we will end with some conclusion. So COVID-19 is a viral infection that can be transmitted through coughing or sneezing, and it's known that the symptomatic people, those who have COVID, can transmit it, and the incubation period is between 7 and 14 days. In Rwanda, the start of COVID-19 was in March 14, and the total population, this number of total population is from the world meters, was of 13 million, and as of March 18th, 2022, less than 1% of the population has been affected by COVID-19. The recoveries were 98.8%, while 1.1% didn't survive, and we still had some active cases. So what we want to do is to use mathematics to incorporate these characteristics of COVID-19. So the mathematical modeling is just a real-life representation of a system that uses mathematics. With mathematical modeling, if we have a mathematical model, we can make calibrations and run some simulations, and with those simulations, we can be able to control the spread of the disease. We can provide projection on the behavior of the disease in the future. We can provide description of the history of the infections among populations or at the individual level, and we can provide insights into the impact of interventions, control measures. So our objective is to develop a compartmental model that takes into account specific characteristics of COVID-19 in Rwanda and the control measures put in place by our government. And we want to use some reported data from RBC to estimate parameters. And in the future, we want to make some projections. So we haven't yet made projections, but we intend to. So our model, so it's a compartmental model. We have a total population N, and this total population is divided in classes according to the signs shown by the population. So we have a class of susceptible people, and in this compartment we have people who are not affected by COVID-19 but may be affected. Those people, if they be in contact with people suspected to have COVID-19, they move to quarantine. We also have people from outside the country who come who enter the country, either Rwandans or other Rwandan residents, in quarantine. And if those people are in quarantine test positive, they move to the compartment of infectious or infected people. If they test negative, they go back in the suspectable group. And in this susceptible group, we can have people who have been infected but don't show symptoms, so they are exposed in E. If they show symptoms, they move to the compartment I. So we have some fraction of those people who move from one compartment to another. And in I, affected people, we have some affected people who are not documented, those who have been afraid to go to the hospital and make some tests. And we have people who have been tested positive and moved to the hospital because they showed some severe symptoms. We also have affected people but who are taken care at home because they don't have severe symptoms. So those ones, if they show severe symptoms, they are taken at the hospital because they are monitoring them, they are under surveillance. So if they show severe symptoms, they are taken to the hospital. So among those infected people in IUH or IH, a portion of them, they get recovered, and they're in the compartment R. And if they don't recover, they just don't survive, so they're in the compartment D. And all those compartments are being connected. And recovered people, they get vaccinated. People who are susceptible, they get vaccinated, and vaccinated people, they go back in susceptible compartment. So all those numbers, they show us some fractions, some days, and some probabilities from moving from one compartment to another. So if, for example, if someone is moved from susceptible to E, we have an arrow that goes. So we use a minus sign in our equations. And if they enter, we use a plus sign. Next, please. So with this, we have formed some set of equations. Those equations show us the change in one group with respect to time, so 2 days. If we take, for example, this equation, they're formed the same way, just by looking to the previous compartments. We have entering people who enter the susceptible group, newborns, for example, and we have those ones who have tested negative, come back to the from the quarantine, and then we remove those who have been suspected of having COVID-19, yes, and then those who have been vaccinated, and we have those ones coming back. So we have formed those equations and try to solve them. We have those parameters connecting them, like lambda, like a sigma, like beta E. So those are parameters that we have tried to estimate. Some of the parameters are known from the literature, other parameters are not known, and other parameters can be known from data from RBC. So for the unknown parameters, next please, we have used the least square method. With the least square method, we try to minimize the relative error between the cumulative number of diagnosed cases of COVID-19 and the deaths reported by RBC, and those ones, so the cases estimated from our model, both deaths and affected. So since we have a set of differential equations, nonlinear differential equations, to solve them we need some initial data. Those are, we take the number of people who have been seen on March 14, so we can see that infected people, hospitalized and susceptible had individuals in there, but we didn't have other patients in other compartments. And for our simulations, the end time was February 18th, so we grouped the data in terms of weeks, and we had 100 weeks in total. And the population is this. Next, please. So we're using MATLAB, a software that helps us to run some simulations. We have found that the total contribution to the disease is of 10.21%. So the disease contact rate in compartment, so of infected people, exposed, undocumented, home-based taken care and hospitalized have contributed to the disease transmission. And we have seen that among 100% of infected people, 64.74% didn't show up, so they were undocumented. And we can say that that is maybe the source of the spread of the disease among the Rwandan population. And 34.74% were treated at home. Among those undocumented, a small fraction of, we observed a small fraction of death, so 0.05%. And we have seen some transition rates from one compartment to another. Next, please. So we saw from our results that the mean latent period is of 5 days. And we have seen that the probability of dying of COVID-19 while you are not treated was of 94.74%. So there is a high probability of people who are not treated to succumb by COVID-19. And we have seen that people who were treated at the hospital have recovered at the rate of 99.5%, and those who were treated home-based cared were 93.21. And the reason is that if people showed symptoms, they were moved to the hospital. So we can see that we can say that 93 it's low, but it's not low because those who have shown symptoms has been moved to the hospital. Next, please. So the table below, we have made comparison about the number of people who have been infected by COVID-19 and reported by RBC. On 18 February 2022, we had this number, and from our model, we had 132,029 people, while from RBC, we have those who didn't survive, 1,454, and from our model, we had 1,358, and for vaccination, the data is from 20 February 2022. So we had 7,730,751, while with the model we had 8,006,053 and 110. So we can see that using our model, the difference between the reported cases by RBC and what we got from our model is not significant. So next, please. And we have tried to now to plot the cumulative cases. The solid lines show the results we got using our model, and the dot lines are the one from RBC, so we can observe that there is no difference. And with the death, we have a similar result. Next, please. So with the death, we have we can observe that there is no significant differences between the results from the model and the results from RBC. So next, please. Next again. So this have been talked about. So we can conclude that we have designed the model, developed the model, made by 10 compartments that's showing the behavior or how COVID-19 is in Rwanda, and we have some equations and nonlinear differential equations that we solved. And for estimating parameter, we used the least square methods, and the results show that there is no significant differences between the results from the model and the result obtained from RBC. And we can use this model to predict the future behavior of COVID-19. Next, please. And for the future work, this is what we want to do, just make a prediction of future infection and the prediction on the impact of control measures in Rwanda. And something else we want to do is to analyze the basic reproduction number, because we have some theory behind that. The infection comes from infected people, exposed, and home-based cared, and we want to analyze that. So how many people can one infected people can infect? Thank you.
Thank you very much. So let us just ask one question to Lydia and another question to Christopher. Okay, I can see. Okay.
Thank you. To Christophe. I have a question to Christopher. He said that orthopedic surgeries were most affected, I think, if I had heard well. And I'm wondering if it is not because during lockdown, some activities that may lead to orthopedic disease, or like, fractures are related to activities road traffic accident and others. I'm wondering if it is just that reason that orthopedic surgeons did not have cases, unless there is a long list after lockdown. Otherwise, I'm wondering if that one can be attributed to lack of care, or that fact that there were less fractures and yeah. Thank you.
Thank you very much for a good question. As I said, we previously already know that we had the unsustainable waiting list of different surgical cases across different surgical specialties, including orthopedics. But during as you said, during the lockdown, of course, the cases decreased because there was no movement, and even those a few didn't get, those who managed who happened to be injured didn't get care because of the movement of lockdown, and then that small number were topped up on the pre-existing number, and the numbers we are seeing currently reflects that there has been a long list waiting that didn't consult during the lockdown, during COVID period, and the number we had before had really increased, comparing all numbers or specialty combined. But as you said, in orthopedics, the number really were not high during orthopedics due to restricted movement or stay-home policy. Thank you.
Okay, thank you. Question to lead. One question to lead before we break for 20 minutes. Thank you. Eva.
Thank you, Lydie, for the great presentation. I don't know where Lydie is. Oh, yes, thank you. I have two questions for you. The first one is, correct me if I'm wrong, but did you estimate all the parameters as actual values, or are some of the parameters that you presented representing functions? And what I mean here is, for example, when you're talking about the infection rate, the contact rate, and so on, are they fixed values? Which means by estimating their values, you are kind of estimating the average throughout the last 2 years, or are some of these functions that you define in a certain way? So I would like to hear more about that, so that we know if you're assuming, for example, the contract rate is the same during lockdowns and when we have lesser measures. My second question is on the vaccination compartment. So I see there is a vaccination compartment which allows you to basically kind of keep track of people that are being vaccinated, I guess. However, we know that vaccination is actually lowering the capacity of a person, for example, to catch COVID, or even the infectiousness once they actually catch the disease, or their risk of getting severe symptoms. However, when I look at the other compartments in terms of infected people, the different compartments, you are not doing distinction between vaccinated and unvaccinated people. Would you care to elaborate a little bit more the rationale from having that compartment vaccinated people alone and not having an effect on the infectious compartments? Thank you.
It's because I start from the last question. At the beginning, we have assumed that infected people, vaccinated people won't lead to severe symptoms. So if vaccinated people get tested positive, they can still get tested positive, but they cannot show severe symptoms, so they can still be treated at home. That's the assumption that we have made. From the first question, there is another question, the first one. Can you repeat it again? Sorry.
Okay, yeah, so let me summarize. So the first question was, are the parameters that you have time dependent, or they are like constant?
They are constant.
Okay, but you can discuss more with Lydie. Can we clap for Lydie, please? And can we clap for Christopher? And then let us have 20 minutes only for tea break. Thank you. See you in 20 minutes.
He's not online? She's not online? My team. She's not online. Okay. Hello, Denise. Hello, Miss Denise, can you hear me?
Yes, I hear you.
How are you?
I'm fine.
Yeah, so it's your time to present on evaluation of performance of rapid test for detection of so are you ready?
Yes, I'm ready.
Okay, thanks. Over to you.
Hello, everyone. First of all, I would like to say thank you to the chief, to the president of organizing committee and the member for the work done to make this meeting a success. Thank you to the monitor and member of this session. Thank you to all the speakers who are doing an excellent presentation on the interesting research. And thank you to all the participants present on the first Rwanda STI conference. This morning, we talk about our study entitled Performance of a Rapid Antigen Test for the Diagnosis of COVID-19 using Nasopharyngeal Symptom. Please, can I see my presentation? Okay, thank you. Our presentation will be made according to the following plan. Next, please. Note that coronavirus is a costly spherical enveloped single-strand RNA virus with a cross-linked appearance in electron microscopy. Coronavirus disease was reported in late December 2019 in Wuhan, China, in respiratory specimen obtained from patients with severe pneumonia. This virus spread rapidly around the world and was declared a pandemic by the World Health Organization on March 2020. So, since the first cases were reported, the rapid emergence of the COVID-19 pandemic is a real public health concern worldwide. The detection and isolation of cases and their contacts are considered essential to help reduce this pandemic. Considered by the WHO as the gold standard for the biological diagnosis of COVID-19, RT-PCR is used to detect SARS-CoV-2 RNA. However, this test has limitations in terms of slow results, cost, the need for sophisticated equipment, and high trained personnel, resulting in a critical delay in the early management of the patient. Next, please. Due to the rapid spread and increasing number of cases of COVID-19, rapid and accurate detection of the virus is increasingly vital to control source of infection and prevent disease progression. For this reason, several antigenic tests have received emergency use approval from the Food and Drug Administration. Similarly, WHO has issued interim guidelines that rapid antigenic tests with a sensitivity of at least 18% and specificity of 97% may be considered for diagnosing of active SARS-CoV-2 infection when nucleic acid amplification tests are not available, or if the test time slows down the management of a potential case. Next. The market pressure generated by this pandemic has resulted in several of the Pambio COVID-19 antigen rapid test devices based on the qualitative detection of SARS-CoV-2 core protein in nasopharyngeal specimen, with as references RT-PCR has performed at the Centre de Recherche pour la Santé des Armées, located in Yaoundé, Cameroon. Next. To do this, we ask ourselves the research question: how does the Pambio COVID-19 antigen rapid test device perform the diagnosis of COVID-19? To answer this question, we set ourselves the general objective. Next, to evaluate the performance. Next, please. To evaluate the performance of the Pambio antigen rapid test device for the diagnosis of COVID-19. Specifically, next, calculate the intrinsic characteristic of the Pambio antigen. Calculate the extrinsic characteristic of the Pambio antigen and determine the adjust concordance coefficient between the activity test and Pambio COVID-19. To achieve our objective, you use the following methodology. Next, please. A prospective cross-sectional study was conducted at the CRESAR during 6 months. 2 sets of nasopharyngeal swabs were collected from 50 who approved their participation to the study, one for the RT-PCR reference test and the other for the Pambio test, according to the manufacturer pre-established protocol. Data analysis was done during R and INSPSS 21 software. Confidence interval was set at 95% and p-value less than 0.05 were considered significant. This methodology allows us to have the following result. The average age of the study population was 32.48 years. The most representative age range was between 21 and 13 years with a rate of 14%. This result is similar to that found in Aruba by Gremlins and also the study conducted in Spain by Brunet. These results could be explained by the fact that this age group representing the active population will be more exposed to COVID-19 and therefore constantly screening. In addition, 76% of those studied were male. This result is different from those found by Torrance, while the author has a predominance of female in their population. However, a similarity of these results was obtained in the study conducted in Douala, Cameroon in 2021 by Gaba. This could be explained by the fact that in Cameroon, males are the majority in the employment sector. Therefore, they are most likely to come in contact with a COVID-19 positive person in the environment, which is why they are continuously screening for the disease. Next, please. Of a select participant, 32 were vaccinated with COVID-19. This result is close to the prevalence of vaccine people in the world in November 2021, which is 39% according to the WHO, and does not match in the prevalence of a vaccinated people in Cameroon in the same date, which is 2.3%. This result and this difference could be explained by the majority of the people who participate in our study, why is constantly traveling to foreign country, and most these countries require vaccination against COVID-19 before traveling. In our study, 22% of participants had at least one symptom of COVID-19, and 8% were in contact with a COVID-19 positive person. It was not that this result was inconsistent with the study conducted in Spain by Merino. while 86.6% of patients were symptomatic and 13.4% were in contact with a positive case. This discrepancy could be explained by the fact that the authors select the participant based on the suspicion of COVID-19 infection or contact with a confirmed case. Next, please. The prevalence of COVID-19 in the study population were 6%. This is similar to a study conducted among the success players of the start in Interline in 2020 by Weekend, which the prevalence was 6.3%. This concordance could be justified by the fact that the population recruited in our study were predominantly asymptomatic, like that the population of the author, where all of them are not symptoms of COVID-19. However, the study conducted in the community of St. Martin in 2021 by Kim obtained a prevalence of 14% of COVID-19. This disagreement with the result obtained could be explained by the fact that the majority of the participants in our study were significantly compliant with the barrier measure described by the WHO. It was found in our study that the prevalence of COVID-19 obtained with the Pambio rapid test was 2%, which was different from that found by the RT-PCR test. Please, next. Next. Okay, thank you. It was observed in the following table that 100 of the Pambio test positive person were symptomatic. Next, please. This confirmed that the RT-PCR test can detect the presence of SARS-CoV-2 in nasopharyngeal sample, even when the person is asymptomatic, compared to the Pambio test, which reliably detect the presence of SARS-CoV-2 right in there of the onset of symptoms. However, we found in this study that 100 on RT-PCR positive person developed 100 of the RT-PCR positive individuals were not vaccinated. Because COVID-19 vaccine are developed to limit the spread of disease, the vast majority of people who are currently infected with COVID-19 have not received a COVID-19 vaccine. Please, next. The sensitivity and specificity of the Pambio COVID-19 assay were evaluated with the RT-PCR reference were 23.23% and 100% respectively. This result is inconsistent with those obtained by the authors. This difference is due to the fact that the sample size obtained by the authors was much larger than the one found in our study. Moreover, the participants who came for a COVID-19 diagnosis for travel, the majority of the study population was made up of asymptomatic participants who came for a COVID-19 diagnosis for travel to a foreign country. A similar result was obtained in a study performed in Spain by Brunet, who found a sensitivity of the Pambio test of 23.23% in individuals whose region for testing were unknown. Next, please. Next. Thank you. The positive predictive value were 100% and negative predictive value were 96%. This result is similar to a study performed by Christinen in 2020, where the positive predictive value were 98.4% and negative predictive value of 98.3%. This similarity rate states that the Pambio test have a high probability to say that the test, when it's positive, is actually positive, and also the high probability to say that the test is negative when it is negative. Current kappa coefficient of the PAMBio was 0.48. This result means that the agreement between the RT-PCR test and PAMBio is moderate. This result is different from the study conducted by Garcia Gardner, where the agreement between RT-PCR and PAMBio was good, and by Marino, where the agreement between the two tests was excellent. This could be justified by the fact that this coefficient is closely related to the prevalence of the disease in the region where the tests are used and during a well-defined period. Next, please. Next. Next again. Okay. This study will contribute to the scientific and health fight of the choice of the appropriate test for a rapid diagnosis of coronavirus disease 2019. Next, please. In conclusion, the prophylactic cross-sectional study was conducted on 15 participants with a mean age of 32.48 and the predominance of male. The prevalence of COVID-19 in the study population was 6% for the RT-PCR test and 2% for the PAMBio test. The sensitivity and specificity of the PAMBio COVID-19 antigen were 23.23% and 100% respectively. The positive predictive value and negative predictive value were 100% and 96% respectively. Next, please. Yes. The concordance between the reference RT-PCR test and PAMBio COVID-19 was moderate. We can see that the PAMBio COVID-19 rapid antigen will not perform well for the diagnosis of COVID-19. However, these results are also indicate that it will be appropriate to use this test for COVID-19 screening in the population. Next, please. This is all the references who help us to discuss our results. Next. We can end this presentation without saying thank you to Université catholique d'Afrique centrale, Centre de recherche pour la santé des armées, Metabiota, and all the participants who help us to make this research. We say thank you to the Dr. Novengai Julius to help us for this research. Thank you.
Okay, thanks, presenter. There might be some questions or comments, but you will hear them after the next two presentations. The next presenter, please, Evarist. He will be presenting on predictive and prescriptive analytics for prevention and detection of COVID-19. Thank you.
Thank you. Moderator, my name is Everest. I come from the University of Rwanda, College of Science and Technology, specifically the African Center of Excellence in Internet of Things. I highly welcome you to our presentation titled Predictive and Prescriptive Analytics of COVID-19 Prevention and Detection, an IoT application. May you please, okay, thank you. It's part of the continuous research that is supported by National Council for Science and Technology. I represent a team of 5 researchers, including one from a partner institute, which is SRM Institute of Science and Technology. Others are both faculty members and graduate students at the University of Rwanda, College of Science and Technology. Next, please. Well, our presentation content will include the background of the project, the main research aim and objectives. I want to introduce to you what Internet of Things is, but specifically the medical perspective of it, and then I'll highlight a brief list of related works. The research motivation, as I said, this is a continuous research work. I'll present to you some results of the previously conducted baseline survey, and the identified gaps, and then the proposed technological solutions towards these challenges or gaps. And then I'll conclude and state the future work. Having originated from Wuhan in China, COVID-19 is no longer a Chinese issue. It's a global concern. So even though we see the ease of the pandemic nowadays, but we also witnessed a complicated mutation of the virus. Recently, a subvariant of Omicron known as BA.2 was very common in some parts of the world. So this calls for a continuous strengthening of public health systems and response. So specifically for this project, we conducted a baseline survey to monitor the level of practice for safety measures enforcement. We realized that in the reluctance of respecting health measures towards COVID-19, this led to an increased number of COVID-19 cases. So continuous monitoring of health precautions towards COVID-19 would actually slow down the spread of the virus. Next, please. So our aim is actually to build on the conducted survey and build technological solutions. Specifically, we realized that front desk employees were at high risk during the spread of COVID-19. And our first objective was actually to implement an IoT-based kit that would estimate a distance between a front desk employee and customers. But also this could be scaled up to inter-customer or social distancing monitoring in public gathering. And then, as we all know, COVID virus was transmitted through probably mouth, nose. So we intend to conduct a continuous monitoring in public environments that would detect unfitted face masks and alert accordingly. And then we realized that the only vital sign that was monitored for any suspect of COVID-19 was a raised body temperature. So the intention was also to introduce some other vital signs monitoring, including heartbeat rate, the level of oxygen in blood, and if possible, some others. And then the intention was also not only to monitor, but to communicate these parameters to the end users that are truly concerned. This could be medical professionals and so forth. Next, please. Then what is Internet of Things? We are entering in a digital age where it's actually possible to fetch and collect data from almost everything. So Internet of Things is a new technology that connects both physical entities, software applications, human personnel, and almost everything. And then we are able to communicate with these entities. Basically, I've sketched a generalized IoT architecture, but as I said, it's a medical perspective. We also call it Internet of Medical Things. So basically, a general IoT architecture comprises of 3 layers. One is a physical, we call it perception or things layer, where we gather phenomena from environment. Then the next layer is a network layer that permits us to communicate the gathered parameters to the end users. And the upper layer, we have an application layer through which we really interact with an IoT system. I've liked these two key features of IoT. We have been spending a lot on developing such a systems, but with the introduction of miniaturized technology, we are able to implement a robust but at the same time cost-effective using this technology. So we can spend less and build some important systems. Next, please. I've included this scenario. I've called it a challenging scenario, but I wanted everyone to have a feel of what IoT is. We have a patient transfer from probably a resource-constrained healthcare, and this patient be transferred to a referral hospital for advanced diagnosis or treatment. But then along the way, who knows the status of this patient? Does the healthcare still have a connection to this patient? Is the referral hospital having some information of the incoming patient? I doubt, especially in the developing world. And then to add on, does the ambulance driver have information of the traffic volumes of the routes he's taking? I doubt in some countries, no. But with IoT, we can build a cost-effective system actually to interconnect all these systems. Next, please. You can skip this, some related works. So, as I said, the motivation behind this research was a preliminary survey that was conducted in 2 districts last year, May. So, we wanted to have an idea on how in public places people are respecting some health measures put in place that was sometimes actually causing controversies between law enforcers and the population. And then how are vital signs monitored, and then how can we check in gathering that so and so is putting on his mask properly. If you wish, you can access the data of this survey. We have hosted the data and it is publicly accessible at that link. Next, please. During our survey, so almost 46% of the interviewed, the responses in social distancing between a front desk employee and a customer was that they knew that this was put in place as a law, so they believed everyone respects. So next. You've skipped a slide, please. And then in vital signs monitoring, we realized that about 36% was using a digital thermometer to detect a raised body temperature as a vital sign for COVID-19, and 29% were not. This was from the case study areas, as I said. Next, please. And as far as fitted or unfitted face masks detection, 96% were checking this by eyes, and this is where I said it was causing lots of controversies between law enforcers and population. So you really don't know that so and so his mask is covering specifically the mouth and nose at the same time. If it is halfway worn on the mouth, this was causing some misunderstandings. Next. So all these data and the motivation we derived from the presented results, as I said, this is a continuous research. We designed a low-cost but helpful test kit. It comprises of a distance measuring sensor. I covered the face, but this kit was deployed in one of our offices at the university to protect our admin staff who receives students' inquiries on a daily basis. So every time a student navigates in a less than meter proximity of the device, it alerts both the employee and the student himself. Next. And we are able to tell at the end of the day that you have experienced this number of incidences that people were approaching you in less than a meter to alert him. Next, please. And then the next solution was to make sure, apart from a raised body temperature, are we able to monitor some other parameters? As I said, we combined a contactless temperature sensor with a pulse oximeter sensor that can monitor both heartbeat rate and the level of oxygen in blood. So the logic was we could not depend on a raised body temperature. So if we realize that the body temperature is greater than probably 37 degrees Celsius, can we then take some other parameters, and then this kit has got a Wi-Fi built-in module. We are able to communicate all these parameters probably to a health professional that is close to the area of monitoring. The device is still under development, and once finished, we can test it broadly. Next, please. So we have managed to transmit these levels. We can monitor and transmit through a web-based dashboard, and this is a front-end application. So we can connect this to either doctors, nurses that are monitoring the devices. Next, please. And for unfitted face masks, we used an AI algorithm, and we trained it with some data. We tested it on different visual sensors, IoT sensors, and different cameras. And in a cloud day, it is able to detect who or whose mask is not properly on. If you can see, we were testing this. It is a lab-based testing, and it was able to realize whose face the mask is not properly put on. So in conclusion, in this work, we have, based on the challenges realized from a baseline survey, and we have attempted to build some technological solutions towards the challenges. Next, a list of references. We shouldn't wind up without extending our acknowledgements. As I said, the project is receiving a direct financial support from NCST. We acknowledge their support, and then the University of Rwanda, College of Science and Technology, especially through the Hosting Research Center, the African Center of Excellence in IoT. And we could not forget to acknowledge our partner institute, which is SRM, Institute of Science and Technology. I guess one of them might be online following the presentation, and probably she may have contribute something if she's online. I thank you.
Thanks, brother. Next presenter, Yvonne, where are you? Can you clap for her, please, so that she can hear up?
Good afternoon. The presentation, please. It's the presentation of Jean-Jacques. Okay. My name is Frank Kwizera, and I'm here representing Dr. Jean-Jacques Chizirungu, our principal investigator, who didn't manage to make it here today. Our research study was titled Quantifying Productivity Gains from Using AI in Detecting COVID-19 Patterns from Chest X-rays. Next, please. Next, again. This is a demo video, but you can play it afterwards. So the background of the study was, according to the preliminary research, it was presented that RT-PCR test has a sensitivity of about 71%, while CT scan has about 98%. So we wanted to do the same, but due to the cost of CT scan, we decided to do the same, but using chest X-ray. Chest X-ray. Next again. So we were thinking of developing an AI algorithm that can help. We thought of creating an AI algorithm and a platform that would allow medical imaging specialists to run inferences or predictions on chest X-rays. Next, please. As you can see, these are the screenshots of an algorithm running on 2 different chest X-rays, and was developed using chest X-rays of COVID-19 patients, but this was collected online due to data regulations. So all the images that were used here were the images collected from open source repositories. Next again. Images were collected from platforms such as GitHub, Mendeley, and Kaggle, and we collected images that were confirmed by RT-PCR test. Next again. According to the British Society of Thoracic Imaging, we try to classify images in 4 categories, which is normal, non-COVID, indeterminate, and probable. And we used a data set of about 5,000 images by making sure that each category had about 1,000 images minimum. The engineering team used annotations from the medical imaging, from the medical team. The medical team annotated images by classifying them in such categories, and the engineering team extracted the images and the annotations, and we used different machine learning techniques to build different AI algorithms. Next again. From the results we got from this, we had about a model, a multi-class classifier model that classifies COVID-19 versus normal and other, and has an accuracy of about 93%. Next again. You can see from these 2 screenshots, the first one shows an annotation by a radiologist, and the second one shows both annotation and AI prediction. And after that, the medical team went on to evaluate what the model was doing. We also collected other images and ran an algorithm on them, and the medical team also evaluated the result by saying that this is correct or incorrect, and if it's incorrect, what's the correct class. Next again. We see this tool very useful, especially in screening COVID-19 patients in areas with low resources, and let's say in hospitals where there are no radiologists, this can be used. And also, according to the model's accuracy in predicting the image, you can be able to prioritize the sickest. Next again. We've seen challenges in doing this because we had to use open source images, especially from Europe and Asia. We never had a chance to use local data due to regulations. not only in Rwanda, but Africa as a continent. And we also had, maybe Keza can explain that more, of the case of meeting some pediatric cases. Do you want to elaborate on it? Okay. So, and also in the beginning, there were no COVID-19 chest x-rays done, so we had to look for different sources. Next again. So, we don't see this as something that can replace a PCR, but we see it as something that can supplement what is being done. And from a technical perspective, we've seen that applying some data augmentation and balancing can boost the algorithm accuracy. Next again. Next. And also, we would like to thank King Faisal as our host institution, and also NCST for supporting this. Next again. And this was done with this team. That's Dr. Jean-Jacques, and that's Odas, the CTO, that's Keza, and down there is Arsene, our machine learning engineer, and Dr. Ivan as one of our radiologists. Thanks.
Wow, it's just 5 minutes you have spent. Okay, so it's a time for questions. I know you had a very nice health break, so you should have enough questions. To our 3 presenters. Okay, so you need to specify whether you are addressing a question to the first presenter, second one, or the third one.
Thank you. My first question actually is not a question, but a comment from Denise. So I saw a mixture of languages, English and French. So she should opt for one language. The other one is a question for specific objective. So she said she will calculate the characteristics. I don't understand this, if it is a quantity variable or a quality variable. Yeah, I think that is for the news. So for Twahirwa, detecting control measures, temperature, guidelines for COVID using IoT is a good project. However, I'm afraid that these facilities are there. For example, for the airports, I'm not quite sure, but there is this robot which measures temperature. I don't know if it detects the face mask, but how will your work be different from the existing one? And how is it related? Or how is it different from the existing one? Thank you.
Okay, so can you allow Dennis to respond, please? She's not online. Maybe someone can respond on behalf, but not a moderator. I'm sorry. Okay. Everybody. Okay.
Thank you for the interesting question. The relation is that if the robot measures body temperature, so does the application. So this would be the similarity or the relation. But the difference could be the environment of deployment. For instance, these robots have got, they are nice, but they are tele-robots, which limits them to navigate into some rough environments. So we can deploy this sensor everywhere. So that would be one thing. One more, as I said, one of the benefits of IoT or these sensors, they are cost effective, they are very cheap in the sense that you can get it at less than 5,000 and do your implementation.
Could you comment about the effectiveness in terms of the results? Which one is accurate?
Basically, in this field, there is a challenge. The results will depend on various things. One, the manufacturers, but what we do before sensor deployment, we do calibration, sensor calibration. We do a comparison with the existing commercial other sensors, which are of course more expensive than these IoT sensors, and then we can do deployment without fear. So the results will depend on, we do calibration before deployment, and that gives assurance of the accuracy of the results we are going to get.
Thanks. I saw you want to ask a question? Good. Which presenter?
Yeah, thank you so much. My comment goes to Everest, but one has been answered already, because I wanted to ask about that, how it differs from the existing ones, because even at different hotels here, when you don't have the face mask on, or you're not putting it on well, then it notifies you that you have to wear correctly your mask. So that there is no innovation in that. And again, about the temperature, same thing. But maybe if this one, if they want to make it more effective, I think they can try to insert sensors in devices which are mobile. I mean, they can make it mobile. That will be more effective, like watches, and even having the sensors embedded in the body, because that's where we are heading, like in the coming future. So this is just a comment, so it's not a question. Thank you.
Yeah, so I think, we should really thank CST, because this is a platform where people interact based on your presentation, and then there are comments that are very constructive with the respect that you are going to improve your work. Okay?
Okay. Okay, thank you. I'm Dr. Jean-Claude Habumugisha. I want to ask one question related to Everest, who has talked about some Internet of Things. My question is about social distancing, which might be a very big challenge during the management of the outbreak. When you consider what they did, is their tool able to detect the social distancing in a crowd, not just between two people, or what is its capability when it comes to crowd management?
Thank you. Maybe I'll first give a brief explanation to the first question, which says the installed system at KCC, it might be effective, yes, but if you remember in our presentation, we are connecting these devices to internet, and the thing is not only to notify the person specifically for body temperature, but again in other cloud places, like where we conducted the survey, and my dear sister can agree with me that if we currently board a taxi and reach Nyabugogo car park, we won't find such a system. And deploying all these at KCC will be costly. So that would be one approach. And then the latter, I actually mentioned it that for this particular social distancing, we are protecting the front desk employees, but in my presentation, I said it's still scalable. We can actually implement to detect the inter-customer social distancing. It's very possible, and this would actually shape our future research in scaling up our device. I thank you.
Okay, thank you very much. Unfortunately, the time is not on our side. Can we clap for our three presenters, please? So the next presenter is Professor Wilfred Ndifon. He is a professor of theoretical biology and serves as the chief scientific officer at African Institute of Mathematical Sciences. He has made important contributions to a range of topics at the interface of mathematics and biology, including discovering a mechanism that allows for viruses to escape from antibodies, with significant implications for the design of more effective flu vaccines and a physical mechanism that governs the generation of the age-old problems of original and genetic sin. Recently, Prof. Wilfred was part of the team that developed a new mathematical approach to pooled testing, which has produced substantial testing efficiency gains in a field application conducted in both Rwanda and South Africa. Distinguished guests, ladies and gentlemen, let us welcome Professor Wilfred Ndifon, who is going to present online. Over to you, Prof. Wilfred, if you can hear me. We can see your slides and also we can see you, but we cannot hear.
Oh, that's strange.
Okay, now we can hear. Very good.
Okay, very good. Yeah, so I want to express my gratitude to the organizers of this conference. I think it's been really enlightening. I've seen and listened to some really interesting presentations this morning. So it's a real pleasure to join you and also tell you a brief story about some of the things that we've been doing. I'm going to focus on a framework that we're currently developing to enable the early detection of epidemics. This framework is being elaborated, and in the process, we're also developing some tools and technologies that would make possible its implementation. This is joint work with colleagues from the University of Rwanda and IMS. Very briefly, I'll tell you why it's important to detect epidemics early, and then I present a sketch of this framework I mentioned earlier, and then tell you about one of the methods that's part of this framework, the way we see it being rolled out in Rwanda and also in other countries. So it's very important to detect epidemics early because that gives you more options for control, for intervention. The earlier you detect, the more probable it is to prevent it completely. So if you roll out interventions early enough, you may prevent an epidemic from occurring at all within a population. But once the epidemic is already in process, once it's already happened, then the only option that's available is mitigation. And so, and the longer you wait to detect and respond to an epidemic, the greater the costs, the human, economic, and other societal costs. So we need to reduce the costs, reduce the number of lives lost, reduce the economic damage caused by epidemics by developing systems that would allow us to catch epidemics early and intervene. So how can we do that? There are just three basic elements to this framework. You need a system for data collection, routine, continuous data collection. I'm going to say a bit about that. You also need to be able to detect signals from data. Data don't give you information, and you need information. You need signal. You need to separate the signal from the noise and determine, for example, if you have a few cases of a disease in a particular place, it might die down on its own without any intervention. In fact, there are some methods that we can use to calculate the probability that given this number of cases, we'll have an epidemic if we don't do anything, or that the number of cases will just die down. So you need to make sense of the signals you detect in the data, and then you need to intervene. So you need a continuous interaction between the people collecting data, the people analyzing, and the public health and decision makers in public health who are designing interventions and implementing them. For data collection, there are a variety of options. You can have systematic approaches like going out to do mass testing. You can also do wastewater testing. In fact, we've been developing methods for wastewater testing. But today I'm going to mostly talk about the mass testing, screening of people. You can also take advantage of primary care visits or immunization campaigns to collect data that would inform the assessment of whether an epidemic might occur. And when you're doing testing, you have a variety of methods available to you. I've just listed here a few: RT-PCR, serology, antigen tests. We've heard from Dennis earlier this morning about antigen tests. I'm going to talk mostly about a pool testing method. And the reason for this is the following. So we need the methods that we use for data collection, they need to be fast, affordable, and reliable. RT-PCR is a gold standard for detecting a variety of infections, and it's in general reliable. But when it comes to mass testing, it is neither affordable nor fast. And we saw this at the advent of COVID-19 in early 2020, when we had limited reagents, limited machines, limited human resources to conduct the RT-PCR tests at the scale that was needed. Pool testing is a way to convert RT-PCR into a method that is fast, affordable, and reliable for mass testing. And it's been applied in Rwanda in the fight against COVID-19 with very productive results. So I want to pause and emphasize the importance of a collaboration between scientists like us who develop methods and the decision makers in public health who ensure that those methods can actually create the societal value that we want. Very early in the pandemic, I think Rwanda, the government of Rwanda was one of the first in the world to receive a formal request to roll out pool testing. And because of the quick decision making of the government, we actually had to go ahead to do a proof of concept test for this method, which after being successful were then integrated into the framework for testing in the country. So this close collaboration is really important if you are to generate substantial value from the basic work that we're doing within universities. Now, the basic idea of pool testing is the following. We don't need to test everybody. So if you have 13 million people or so in a country like Rwanda, and you want to know how many people are infected, the first rule is you don't need to do 13 million tests. You need to sample people from the population. And even when you sample people, I've shown up on the top right-hand corner of this slide, some people whom I assume I sampled represent a population. So I've sampled these 9 individuals from my population. I don't need to test each of the 9 individuals to know how many are infected. In fact, what I can do is pull samples from this individual. I can group them in an intelligent way. And our method, the pool testing method we developed, shows us how to group these individuals. Like if I group them, for example, in the first stage, I can put these 9 people into 3 groups, each group of 3 persons. If I pull the samples from each of these 3 persons in a given group, and I test the pooled sample, I'm going to discover that only one of these groups contains a positive person. So because only one of my 3 tests will be positive. Then now I can separate those 3 individuals into groups and test them. In fact, here, that simply means individual testing. So in the second stage, when I test these people, I identify uniquely the person who is identified. And I've done 6 tests, not the 9 tests. So I detected an infected person among 9, a total of 9 people, by doing 6 tests, not 9 tests, which would have been the case if I was testing people individually. This is a simple example, but actually the cost savings can be much more substantial. You can have more than 10-fold cost savings at moderate infection prevalence and more than 20-fold cost savings at moderate to low prevalence. So how does this work? I have a challenge here. I need to present this mostly by using illustrations. I'm not very good at drawing things, but I'm going to try to help you imagine how this works. So imagine that you have a building, so a story building, and the length, the width, and the height are all the same. So they are, it is basically a cube, okay? So the length, height, and width are the same. So let's imagine that this building has 3 floors. And on each floor, you have 9 rooms. Each room has the same length, width, and height. So if you stand outside the building, in fact, you can see the building, the rooms are arranged in 3 rows. Okay? You have 9 rooms in one row, 9 in another row, and 9 in the last row. If you stand in front, behind, on the side, even up, on top of the building, you still can identify these 3 rows. So imagine now that you have 27 people, one of whom is infected. So that building has 27 rooms, so you can put 1 person in each of these rooms. Then the question is, which room contains the infected person? And the approach to doing this is the following. So you can stand in front of the building, and then you take 1 row of 9 rooms. You collect the samples from people who are in that row, and then you test. So this is a pool, okay? Mathematically, the terminology we use is that you have this building, which is a hypercube, and then you are slicing the hypercube. You're creating slices of the hypercube, which are then the pools. So you've taken the 9 people who are infected, who are in the rooms along one of those rows. You pull their samples, you test. You pull the samples of 9 individuals who are in the second row and in the third row. So in that case, you have 3 different pools, and you do 3 tests. So you are in front of the building. Now you go to the side and you do the same thing. You take the 3 rows, pull samples from all the 9 individuals in each row, and you test. And then imagine you could climb on top of the building. You also see those 3 rows, and you do the same thing. In the end, you have 9 tests from the front, the side, and the top. So essentially, you've sliced your hypercube into 9 slices of pools. So you do 9 tests, and if you had only 1 person who was infected in that building, the results of those 9 tests, they are like a coordinate system. Those who are familiar with basic math, if you draw an x-axis, y-axis, you can plot points on this plane. Here also, the test results generate a coordinate system that allows you to go and identify the room, the precise room that contains the infected person. So in a nutshell, this is how this method works. There are some challenges in case you have, for example, 2 positives, so 2 rooms that contain an infected individual. If none of these individuals are in the same row, if you look at the rows from the front, the side, and the top, and none of these individuals occupy the same row, then you have an ambiguous result in the sense that you cannot uniquely identify the locations of those 2 infected persons. And what you do is simple, you just slice your hypercube again. Now, if in at least one of these directions, either front, the side, or the top, these two individuals are in the same row, then you uniquely identify the person who is the two people who are infected. And this happens in 2 out of 3 cases. So in 2 out of 3 cases, you don't need to further create slices and tests. You just identify all the positive individuals and you stop. In the case where there are 3 positive individuals in your building, you also have this a non-negligible probability of having ambiguous results, and you have to create slices again to identify uniquely those 3 people. But the nice thing is that we designed the hypercubes. The algorithm, it leads us to design hypercubes in which there is a very small probability that you'll have 3 or more positive cases. So in general, it's relatively straightforward to identify the people who are positive. So I've given you a brief overview of how this algorithm works. I want to tell you now about some of its advantages. So I showed you earlier that if I had 9 people and 1 is infected, I could identify that one person, not by doing 9 tests, but by doing 6 tests. Actually, if I divide the number of tests that I need to do in order to identify infected people by the total number of tests that I would have done if I was testing people individually, I get something that corresponds to the y-axis of the graph that I'm showing here. On the x-axis, I'm showing the prevalence. So what fraction of the population is infected. As the prevalence increases, the number of people you can put in one slice also goes down. And on the right-hand side, you see that you continue to do far fewer tests using pool testing than you would if you were testing people individually. So this is the key, a plot that really shows you quantitatively the advantage, the kinds of cost savings you can expect if you're doing pool testing. And we did this, did a proof of concept study a long time ago. My colleague, Professor Leon Mutesa at the University of Rwanda, did the following. So with pool testing, you have to pool individuals. At the time we started this, it was not known the maximum number of people you could pool together and still get a positive result with a reasonably good sensitivity. And it showed that you could pool up to 100 people, okay? And you still get a positive result. So this was surprising, and it shows that there is really scope to pool and save on costs by using this approach. And in a test that was done in Rwanda in early 2020, we could screen 1,280 people by using only 64 tests. So a 20-fold gain in efficiency. I want to mention a bit something concerning antigen tests because I saw the very nice presentation that was made early this morning about antigen tests. One of the conclusions was that they are not good for diagnosis, but they can be useful for screening populations. We've actually done an analysis showing that for mass testing, when you combine RT-PCR or pool testing, you actually have a method that is 6 times more affordable than the RDT, the rapid antigen test, for detecting infections with a very high accuracy, high level of reliability. And the assumptions are simply the following. So this on the plot you see shows you the viral load typically that somebody would have as a function of the time since they were infected. The time here is in days. And so given these trajectories, and also assuming that RDT, the antigen test will detect a positive sample 95% of the time when the CT value is less than 27. So the CT value basically is correlated with the amount of virus that you have in a sample. And that 65% of the time, where it will detect a positive sample if the CT value is between 27 and 30. And by the way, these are very generous assumptions, because in practical cases, as shown by Denise, the antigen tests actually perform much more poorly than what we have assumed here. So given these assumptions, and also assuming that the antigen test costs $5 per individual, while the RT-PCR test costs $56, you get the RT-PCR plus pool testing combination being 6 times less costly than the antigen test for mass screening. So this is just to show you that there is a lot of potential in building the capacity for mass testing in order to enable the early detection of epidemics within Africa if we focus on the resources that are already available in many of our labs based on RT-PCR. We don't need to import gadgets from elsewhere as a means to protect ourselves against epidemics. Now we have gone on to develop an even better method than what we published in Nature. And we did this by exploiting some results from computer science. So there's an algorithm that has been studied for many years, and we were able to extend it in novel ways that allows us to increase the speed of our algorithm first. So now you can do just one round of testing and you identify everyone who is positive. But then also you can do this with, you can use fewer tests to detect the positive individuals. So this is a significant advance over what we have published. And we have validated this in collaboration with Professor Mukesa to show that if you have a group of 384 individuals, among whom there are 5 positive people, you can detect all the positive people by doing just one round of tests. So this demonstrates the speed and also the accuracy of this method. Now, what I have described to you involves a lot of math that is hidden mostly. And that is good, because if you want people to use a method, even though it relies critically, essentially on mathematics, it's good to hide the math so that people only see only have access to what they need to facilitate the adoption. And along those lines, we have developed an online application that allows anyone to use these algorithms that we've developed without worrying about the underlying mathematics. And so the team at AIMS can be contacted for those who want access to have access to this. In conclusion, I have described the framework for early detection of epidemics, which we are working on elaborating. Early detection requires testing, and so I've introduced pool testing, which cuts down testing time and costs. And pool testing is already being used in Rwanda for COVID surveillance, and as a result, the country has saved a lot, has been able to test better than most countries in the world, and in my view, has had one of the best responses to COVID-19 in the world. I want to acknowledge these, my close collaborators, also the funders of AIMS and NCST, University of Rwanda, Rwanda Biomedical Center, and all the organizers in this conference. And so this is how you can get in touch with us at AIMS. Thank you for listening.
Okay, thank you very much, Wilfred, for the presentation. There might be some questions or comments from participants, both who are here and online. So this is time for you to ask questions. Dear participants, anyone with a question, comments? Okay, one question or comment from Dennis.
Thank you, Prof, for your nice presentation. It's really helpful when you are doing this mass testing. However, I have my worry. This may be time consuming to pass through all the phases. if the infection rate is very high in the population. So you may choose a sample, the first sample, then you group, you do the mass testing, you find all the samples are also infected. Then you go to phase number 2. So is it a challenge you have seen also? But if it can be like time consuming, you pass all the phase for a population which is highly infected. Thank you.
Okay, so can I respond?
Yes, go ahead.
Okay. So here I showed the gain that you can obtain depending on the prevalence. So up to 10%, for example, you're getting between 2 to 5 fold cost savings. Of course, as the prevalence declines, you have much higher savings in costs. So that's the first point I want to make. The second point is that the version 2 of the algorithm requires only one round. So you take thousands of samples, you pull, test, and that is it. You put in a software like what they have developed, and it tells you which samples are positive. So this is actually quite fast. And the experience from Rwanda is that pool testing helped to cut turnaround times from what previously was like 48 hours or more to under 24 hours. And that's why, for example, you can get your results. You arrive at the airport, you test, you get the results very fast. You go to the different labs that deal with RBC, they give you your results very fast. In many countries, even in the US, you don't get such speed. So this demonstrates the advantage of applying pool testing in terms of speeding up turnaround time.
Okay. Any question? Any question? Okay, so let's clap for Wilfred. Mary, it's your time.
Thank you, Isam, for moderating this interesting session. And I think now is the close of the morning session. We are heading to the lunch. After lunch, we have one keynote speech. And we are having 3 presentations because one of the presenters is not around. He's not going to present. And right after those presentations, we are going to have a tea break and coffee break. We come back for, I think, for the panel discussion and closing remark by the Minister of Education. After, we are going to head for the gala dinner. So I encourage everyone to make the lunch quick, like yesterday. In fact, it is a buffet. When you are going for a buffet, you can take whatever you want first, and then you can come back. Instead of going on queuing, we can see the long queue. Sometimes people get discouraged. So I encourage you to go and grab something that you like first, and then you sit down. You can even sit down first, and then you go instead of standing, right? So bon appetit.
Hello? Hello? The venue for the lunch has been changed. If you go outside, our people are going to direct you
So it's in Radisson restaurant.
Thank you. Testing. Test 1, 2.
Noela Girimana to come in the front so that he can start the session. Okay, over to you, Noela.
Thank you very much, Marie-Chantal. Can you hear me? Excellent. So as Marie-Chantal just mentioned, we are getting ready to start the last panel discussion. And I do hope that we finish, or at least finish and increase the momentum as we come to sort of the conclusion of day 2. Obviously, we have the Honorable Minister joining us afterwards, and I think the session today is about to be focused on R&D investment, and in the context of the pandemic. Obviously, it is still a very relevant, situation to be addressing. So I'm about to call my fellow panelists, and I'll introduce them as they come on stage. So it's my absolute pleasure to introduce this high caliber panel discussion around strategic R&D investment to mitigate epidemics. I'll start by introducing our first panelist, Dr. Agnes Binagwaho. Welcome, doctor. So you're gonna help me welcome our first panelist, and she's the Vice Chancellor at the University of Global Health Equity, and has had a long career, including in academic engagement in various research. A powerhouse, really. I was trying to read the CV, it's very long. But just Google all my panelists today. I am happy to also welcome Dr. Claude Muvunyi, who is the Director General of the Rwanda Biomedical Center. Welcome, doctor. He's also my boss. So be nice. And so he's the Director General of the Rwanda Biomedical Center and has also strong research in various areas. Also Google him. It's also my pleasure to welcome another high-level panelist, Dr. David Calvin. Welcome, Dr. David. Dr. David is a professor of microbiology and immunology at Dalhousie University, and that's in Canada. So all of them have been keynote speakers. I'm also happy to welcome Mrs. Melissa Rusanganwa. Welcome, Ms. Melissa Rusanganwa. She's the head of Africa Regulatory Affairs at Zipline and brings in a very important perspective. So as we start here, I'm going to maybe turn right away to you, Prof. Binagwaho. So we are in a situation of a pandemic, and many have, we have forgotten, but it's still very much here. And we've been basically managing this crisis, and it's been more than 2 years, and it has had huge consequences. Most of us here are from, or at least linked to the health sector, but the pandemic has impacted, basically it's been across socioeconomic consequences, and we've had to basically work to keep the healthcare system functioning, guarantee continuity of education, ensuring that businesses and livelihoods remain protected, maintaining some stability in terms of financial market. And so all this engagement has actually brought together several sectors. The government cannot do it by itself. We have various actors together. So I want to turn to Professor Binagwaho and ask how we can strengthen the multilateral collaboration and partnership for all these stakeholders, and how do we build resilience in a crisis, and as we look also at potential future pandemics.
Thank you, Noela, and I'm very pleased to be with you. As I said yesterday, it's so great to see human people in real human people, not video one. I think that what COVID has taught us, and it's not the first pandemic we have, but taught us how no country can manage a pandemic alone. Without cooperation, every country is lost. You can do the best. Imagine Rwanda, you do the best. You have 5 borders, you do nothing. So you need collaboration to protect your people. So regional collaboration is important, first of all, to share knowledge. What are the last science? What have you experienced that allow you to control better in these circumstances? So coming together at different level for businesses, for health, etc. So we need guidance, protocol. You don't do that alone. You need result of research. Imagine Rwanda did so well, but so many benefit from so many researches done elsewhere. Also, in the preparedness, we need international organizations such as CDC Africa that has helped African countries to manage on behalf of African Union. Remember how they create a pool procurement. When Rwanda alone or Burundi alone or even Tanzania, a big country like Nigeria, order PPP, the order was not considered even if the country were paying upfront. CDC managed to put everybody together, one order for Africa, so now we have a big voice on the market. So all those a little part of the response and the preparedness need really regional and sub-regional cooperation. So we also have, like now, the pandemic has accelerated the creation of the African Medical Agency. And because Africa is going in manufacturing vaccine, the vaccine, of course, Rwanda will manufacture vaccine. I'm sure within 3 years you will have vaccine made in Rwanda. But for the vaccine made in Rwanda to serve other countries, we need a regional accrediting body, not only our FDA. So to help the creation of such agencies, we need African Union. And I'm very pleased to tell you that it's done. But now we need the ratification in all countries. CDC Africa is helping in that. And this cannot happen without coordination. We talk about research and development. We have now 5 countries in Africa that are really already doing vaccination. How they did it? It was with the support of other countries and African Union. And the way the mobilization of our head of states came together and promote the idea that Africa is fed up to be served last when the rest of the world is served, that it's time for Africa to manufacture what Africa needs to survive. They came together and mobilized to put money where it will be used the more quickly, what was South Africa, but also to prepare other countries like Rwanda, Kenya, Ghana, to go also for manufacturing. So all these are important ways that shows us that regional collaboration are absolutely needed. That now we resume. Remember when your institution was searching where are the hotspots of COVID transmission. And we found that the truck drivers were them. Without a partnership with the Tanzanian and the Kenyan, where the ports are, Rwanda has some land in the port. But what enter in Dar es Salaam and Mombasa for Rwanda need to transit in 2 countries. Without the partnership of those 2 countries, the good will have stopped to come. Or they will come here, putting our people in danger. So those are examples of how to strengthen health sector, but you can strengthen that only by strengthening the entire country, because the transport is not linked to the Minister of Health. We have a minister for that. but also other countries.
Thank you very much. I think I want to also add that what Professor Binagwaho just mentioned, she also walks the talk because she's on the AU Commission on COVID response. Yeah. It's one of the things that I wanted to mention earlier. And so coming back to this aspect of regional coordination, which is so very important, and we talked about how this can help in building resilience, how this can help in mitigating this pandemic. And it's also where we would basically start if ever we were to basically face the next crisis. I want to turn to Prof. David for this next question, building on what we just heard from Professor Binagwaho around regional cooperation, and kind of broaden the spectrum a little bit. When we talk about building resilience when it comes to a health crisis, again, it has impact beyond the healthcare. When we think of building this resilience, there is need to increase investment in terms of public health and in terms of infrastructure, and in many, many ways. I want to turn to you and ask, how can this be done strategically at the global level? Because I think you bring another perspective that is important for us to hear, in particular in developing countries where we are faced with limiting or limited resources.
Thank you. First, I think it's leadership, vision, teamwork, and communication. And that goes from on the global scale all the way down to the micro scale. Because the leadership and vision have to understand what the problems are and where the solutions might lie. And you must incorporate, identify, and bring into a team that can work on this and communicate it. And communicate it not only within their own structure, but also the people that need to be engaged to actually make this happen, whatever it's going to be. On the global scale, we saw that weak leadership led to disastrous outcomes in many countries, whereas strong leadership in low and middle income countries actually benefited to those countries and was really a model for some of the other countries on how to behave. So where do the resources come from to actually get this done? I think it really comes from the needs. Is the leadership in any one of those categories understand what the needs are and the vision, and then how to get their team to communicate it to the stakeholders. Globally, we're all stakeholders, but as we try to bring the individual needs down into the trenches, that's where we see we have to have individual teams on the ground to do it, much like an army. Some of the real success stories in building these things that were important for the pandemic, one to draw on is the lateral flow antigen test, which in itself wasn't 100% effective, but it was a really great tool for understanding population dynamics and infections. And it's cheap, inexpensive, and it's a point-of-care device. And it's a good example of how a global need was brought down into a small laboratory. Prototypes were developed, and then they were mass produced in a very short period of time, and it's a great success story. So what I suggest is we bring in the private sector, who has a long history of innovation, and have them become engaged to the needs from the leadership.
Thank you very much, Professor David. So indeed, we're about to bring in the private sector. I note that you were mentioning that one example how we went from a global need to a small lab where we developed a prototype and were able to scale up. I want to zoom in on the role of one of our members here that is part of the private sector from Zipline. And so one of the key areas that were affected by this pandemic is the supply chain and the supply chain industry. And as we know, Zipline is a major player not only at local and regional, but also global. And I want to add again that it was started here in Rwanda. You do a proof of concept and then you scale. And Zipline is one example of that. But I want to zoom in and ask Melissa specifically how Zipline technology was able to contribute to building resilience in this area. So I talk about supply chain industry, but if you can give us like specific examples.
Thank you very much, Noela. I'm sorry for I kind of lost my voice. I hope you'll be able to hear me throughout. Thank you again for the opportunity to represent the private sector for this conversation that happened since yesterday. So yeah, at Zipline, basically what we are thinking about is, as you mentioned, during this new pandemic, the supply chain basically changed. We got into a position where, as we all know, we couldn't move, goods could not move. It was really hard to sorry. So the movement was really hard. Okay.
Sorry, we want to thank Melissa for coming today. Losing a voice as a panelist is probably not the best timing.
Yeah. So at Zipline, what we were able to do is make sure, we tried, our vision is to basically rethink about how we think about logistics. When we think about logistics, it's about how do we move goods from one place to the other. And the way we were thinking about that in this situation about medical products is how do we make sure to move goods where they're needed and exactly when they're needed and exactly where they're needed. So that's our approach to how we want to redesign logistics. And the idea here would be to kind of bring a model when you have an instant delivery. So the idea is very simple. As I mentioned, how do you make sure that all those goods are being moved and nothing can stop those type of movements? This is really hard, sorry. So Noela mentioned that our partnership with the government started back in 2016. Actually, our first client was Rwanda. So the idea that Zipline basically brought here is actually to improve the health system to the country like Rwanda that wanted to bring technology for a good purpose. So the idea here was, how do you use technology to improve the socioeconomic benefits of the population? So when we came into the country, we basically integrated the health system the way it was and kind of improved it. So right now we are serving more than 400 facilities in Rwanda, and as she's mentioned, we have been able to also expand not only in Ghana but very soon in Nigeria, Kenya, Japan, US, and Ivory Coast. So those would be the countries that will be starting our operation in as well. So now the idea is that every facility at this point that we serve, and I would say at a national scale, every facility is able to not only decide when they need a specific product, request the product from us that we have been able to store, and we can deliver those products within 20 to 40 minutes, depending on the location. So now with the pandemic, what happened, we realized that technology can actually support some of the core processes that the governments were having. So we moved from only supplying blood and medical products to now including PPE, lab tests, sample tests, and also COVID vaccines. So this is one of the ways that we were able to support in multiple geographies. And the other way that we also were able to include technology in the process as a response to the pandemic was also the idea of the lockdowns. People were not able to move. So how do you make sure that someone who has a disease, for example, a cancer, how do you make sure that that person still has access to to their treatment during a lockdown. So this was actually a proof of concept that we actually did in Rwanda as well, where we had many cancer patients that used to go to Butaro Hospital to get their treatments. So now, instead of going all the way to Butaro because of different lockdowns, what we were doing, we were basically bringing their medical and treatments closer to their homes. So the idea was to bring those medication to the closest clinic to their homes. So what we've learned from the pandemic is that the healthcare is definitely also changing, and I think technology will also, again, be playing a big role. The idea of being able to, I heard during the different conversation today, that some of the challenges that we've learned in Rwanda was the fact that people could not reach facilities. People didn't want to leave their homes because they were scared of getting COVID, right? So how do we also make sure that the healthcare is also designed in a way that's and adapts to the new reality? How do you get how do you get treated from your comfort of your home? And I think that's where the healthcare system is heading, and the technology and Zipline is also going to be moving in that direction. Our thinking really is how can we learn from a patient journey as they get diagnosed from their homes and make sure that they also get their medical products at in the comfort of their homes. So as a company, we're basically thinking that's where the direction of the logistics are going, which is basically making sure that they have that instant delivery when they want it, precisely where they want it, in their comfort of their homes. And that's also the direction that we're taking. Thank you.
And Noella, can I add something?
Yes, please do.
I don't know how you do that.
I think it's on.
It's on. So I want to complement what Melissa said because it's a panel about research and development, correct? Yes. Why the proof of concept have been done in Rwanda? You should ask yourself the question. Because for Melissa to work, she needs to have the permit to fly. And this is given through the Aviation Authority, not the Ministry of Health. She needs to have a good insurance in case all those flying machines failed on somebody, and no insurance have insured such a tool. So it was a research. We need also to reassure, because you have flying machine near the border, we need to reassure our friends in Congo and other places that this is for medical product, is not for spying. So we need a diplomatic code in. And I can go on and go on. And in this country, all the concerned sectors came around the table under the leadership of the Prime Minister, because it was too wide. So that means the government came together to change laws, to allow the private sector to give the benefit of our population of something that was new and so needed. So that's how now she said it was the proof of concept here, and other countries were not so used to work together in a multi-sectorial fashion, the army, the civil aviation, the transport, the security, the insurance, Minister of Finance, to come together under the Minister of the Prime Minister, to come together so that the Minister of Health can sign with Zipline. So this is how Rwanda is most of the case in such innovation, a place where it's easy to do the proof of concept. And when I remember some countries want to do that are still thinking how to do that. Thank you.
Thank you. Thank you very much. I think this is a very important perspective that Professor Minogwaho just added on what Mrs. Melissa mentioned. So when you think of R&D and investment, I think there's a theme here that's coming, and that you just kind of crystallized by saying how it brings multiple people together. And in Rwanda, there is certainly willingness
to try. That's why we became a proof of concept hub. A lot of the things that were talked about in the past 2 days actually are a great lesson. And one of the challenges that Prof. Nagwaho gave us was, let's keep disseminating these findings. Let's keep documenting this evidence. And so I want to, if you allow, zoom in on the government, right? So we've heard from academia, we've heard from the private sector perspective, and there's a common theme around strengthening these multilateral cooperation. So I would want to ask Dr. Muvunyi, from your perspective, we heard earlier, you shared how the Ministry of Health, RBC, and all these partners came together to respond to the pandemic, and how we've used technology in many, many ways. If you could tell us a little bit more about the lessons learned, right? We are in a reflective stage, at a place where the current pandemic is still ongoing. The next threat could be, and we try not to be pessimistic, but the next threat could be next door. So what could be important here is the lesson learned from Rwanda vis-a-vis these innovative strategies that we've applied, and we start to document and reflect on this. So we'll turn to you, Professor Muvunyi.
Thank you very much, Noella. I think what we have learned from this pandemic, I can say, is that the pandemic need to fund the system when it's really ready in terms of responding to the pandemic. And I've touched a little bit on this morning. There are 3 areas where we need really to be ready. And the first area is the diagnostic. So we need to really be ready to have a diagnostic security where we have a very strong network in the sense that the diagnostic is available and accessible to all the network at all facilities. And there is to be a need of coordination, so diagnostic capacity, but also the human resource able to really provide this capacity for testing. And we have learned also that we're not ready, and we are still, even though we had previous pandemic in Africa especially, but there are very few evaluation of what went well and what did not go well. So I think we need to really encourage or promote the culture of evaluating all the strategies, all the interventions that has been put in place to really respond to pandemic, so that we can be prepared for next pandemic. And I've also mentioned about therapeutics, so we need to have a system in place to provide treatment for some cases so that we avoid death from the infections, but also vaccine. And vaccine security is also another key area where we need to really invest. And for the vaccines, we are not yet ready, as I can say, because for the vaccine, we need to have research infrastructure, which is there in terms of really having a good information system and data to really inform areas where we need to put much effort. And I think we have learned, even from the support, I think the Prof. Agnes touched a little bit on that, the support from CDC, PEPFAR, Global Fund, and HIV, malaria. But now we need to switch our mind into how can we be innovative. At the same time, we identify some cost-effective intervention. For example, using e-learning system where instead of our skilled staff going on fields to spend most of the times and not getting enough time to think about ideas and research ideas. So we need to keep them at work using data that we get from the periphery at the central level in terms of dashboard and so on, so that we can understand very well how are we doing in terms of our interventions. And this is something we need to really continue to put much effort, so to improve our data system, have a system where everything needs to be evidence-based intervention. So I think with that, I can also say that in terms of research infrastructure, we need also to be able to build the capacity in terms of research, and that will require to work together, because if you did do an evaluation of the impact of pandemic, not only on the health sector, but in all the sectors, at that time, everyone will understand that we need the multi-sector investment in research so that we really prevent, we are ready to respond to pandemic. And I can assure with you that from this pandemic of COVID, we're not ready. We had a lot of investment, but there was no plan to really identify where to put much investment or effort. So I think we also need to be ready in terms of research investment plan, in terms of where to know to invest when we have money. And in terms of research, I think since we know that genomic is very important in terms of knowing what are the genes of pathogens that are circulating. So we need to move from pathogen or phenotypic surveillance to genomic surveillance, where we can really go to understand what are the new pathogens, but also new genes that are circulating, so that we can really identify in real time those new pathogens or variants and really contain that strain before it spreads to the community. So we need to have a strong capacity for diagnostic, good data system, but also human capacity building to really carry out those research. Thank you very much.
Thank you very much, Professor. So as Professor Muvunyi was reflecting on this lesson learned, he was also basically reflecting on strategies that are now in place that we can build from. If you allow, Prof. Binagwaho, I want to turn back to you and ask a question around these existing strategies. You started to mention some, but how these existing strategies in specifically developing countries, I don't think that's the right term, but that's the one we use. All countries are developing. So, but resource limited countries to support and what these strategies are in place basically to support and promote the research and innovation, either for the development, for the manufacturing, for some of the deployment of vaccines. So helping us frame further these existing strategies that we can actually build from as we look forward.
Great questions. And the answer to this question have to go back to the roots of even the colonial time. Where do we have universities that doesn't produce the same thing that we produce in Stanford or Harvard? It's because education was neglected. So we have the strategies, we have great people, but there is a lack of money dedicated to that. Why? Because the budget of our countries are limited. We have also a lack of people who can implement those strategies, so we have to call back all our brothers and sisters that have migrated to exercise their great talent they gain here and go and serve in the developed world, if we can say like that. So that we need also to secure money to pay them, to attract them back and to pay them. We need also to continue to develop our private sector, because vaccine, medicine, and all those tools, diagnostic tests, are developed not by government, are supported by government, but developed by private sector. Our private sector in our countries are still at skeleton level. We need to put some meat around them to make them, to shape them a bit. So we have the strategies, we have the thinking, we can do it, but we need to do that as a prerequisite. Bring back on soil the capacity to do that, the human resource. We need also all universities here to shift the way we are teaching our students and make them and teach them not for today, for 10 years, the 10 coming years. And make sure that for this we need the teachers who can do that. We need the lab where they can exercise. We need, it's very expensive to teach lab technician because before knowing how to do a test, they are spoiling 20 tests, isn't it? And nobody wants to pay for those tests. So the teacher cannot teach, etc. So we need to do what you have said, Professor Muvunyi. However, we need to create the system to, strategies are still blah, blah, blah when they are not put in place. And to put those great strategies in place, change the private sector, change university, equip them, give them money, call back all our brothers and sisters outside. And also, you know, the developed world, we say the rich countries have borrowed our brain during years for free. We can borrow their brain as well, attract here so that we can leapfrog the period. We don't have time to build from scratch. The rich countries have done that over 100 years. We don't have 100 years. Maybe we have 100 days.
Thank you very much. Thank you very much. So definitely we want to move from blah, 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 right? So we want to move from these strategies, it's a word that we use enough, but into systems. So you've mentioned systems that put the resources together, either the human capability on the financial side. You've actually challenged both the private sector and the academic institutions as well. So if Prof. David, I'll switch a little bit and turn to you and ask you the same question. I know this was not the plan, but very interested. I think you bring in a quite another important perspective as a global researcher, and you've worked with China, Rwanda, in addition to your work in Canada. I think you also, we would benefit from hearing from you about these strategies, right? It fits into the significant advances that we've seen, but if we try to crystallize them into strategies or maybe even systems, what have you seen can work for a country?
I'd like to touch on a couple of things that are tangential to this. The first thing is that strategies are great, but the transition from a strategy to implementation does require a culture. And the culture of innovation. So if I have to say, the major difference between Canada and the United States is that the culture of innovation in the United States they have a great deal of wealth and they have a culture of innovation, and innovation without restrictions, so that think outside of the box. And you know, some of the greatest innovations I've seen over the last 20 years have come from resource-poor areas. It's because if you haven't got it, you've got to make it. So I think in a strange way, what you really want is you want to tailor your culture of innovation to fit what your needs are. If you identify the needs and you ask for the private sector or universities, and you can provide them with the resources to move forward, you want that culture of innovation. In China, we're in the process of building a new research institute, and they asked me what I wanted in my laboratory, and I told them I don't want any laboratory. I don't care about the laboratory. That'll come, but the number one thing I want is a coffee shop. And they laughed. And I said, well, why do you want a coffee shop? And I said, because that's where I see my colleagues. And getting together as a group is the culture. And if you can talk and discuss, you want to feed off of each other. You want to feed off innovation, discuss ideas, things like this. So the strategy there is to establish the culture. That's just one example. Another example is, let's talk about vaccine hesitancy. So where do we actually try and engage people for vaccine hesitancy? This is a lesson I learned from Rwanda. We went to the Holocaust, to the Rwanda museum, and I noticed that there was a strong impetus on talking to children. And the really important thing here is that if we could discuss something like vaccines with children in grade school, in Canada, all children get vaccines in order to go to grade school. But nobody ever teaches children about vaccines. But if you taught them the importance of vaccines at a young age, then when they got older and had to make the choices for themselves, at least they would be informed of why they were stuck in the arm. So I think in building that culture of understanding the importance of those items, science, vaccines, things like this, is equally important to all of the other aspects of strategy building.
Thank you. I think it's certainly, I'm hearing a theme between what you're saying, Professor Minangwaho, and what Professor David is saying, building on what Prof. Muvunyi was mentioning around the lessons. So moving from strategy to implementation and building these systems, and also the culture of innovation, culture of understanding of science. And I hope, looking around this room, I'm sure we are, certainly, many of us have benefited, and there's a reason why we're sitting here today on a Friday afternoon on the last panel. It's because the interest is still there. So if you allow to the panelists, I'm very eager to get the audience perspective. I think we've heard from some excellent points being raised from the perspective of government institutions, from the perspective of academic institutions, 2 of them represented here, as well as from the perspective of the private sector. So I want to turn to you, see if you have any questions, any reflections on what we talked about here today. The theme was kind of broad, right? We talked about R&D investment, but we were able to dive deeper into sort of some tangible topics. And so very eager and curious to hear if you have any, around the room, any of comments or questions to any of our panelists. We have a microphone here, so you just raise your hand. We have also a moving microphone over there. And you can just quickly say your name and then the question to the panelists. Thank you.
Thank you, Noella. My name is Joris Chizere, and I work at the Center for the Fourth Industrial Revolution. My question is directed to you, Honorable Director General. So, of course, in the frame of research and development, there's a lot of things I talked about, bringing in the private sector, more contribution there. So, of course, we need to have access to data for all those research and development activities to happen. Of course, the Rwanda Biomedical Center and MOH in general, and these universities in general, but specifically for RBC and MOH, you have a lot of data that could be harnessed for creating interesting, innovative solutions, some of which we're already seeing in the market. So my question is, it doesn't seem to be very straightforward or very easy to get access to this data, even though a lot of times you have a lot of interesting potential solutions that can be created out of this. So my question is, what are you guys thinking to do in terms of streamlining access to data in a way that's, of course, safe and secure, but allows interesting research and innovation activity to happen? Thank you.
Thank you, Joris. I'll take one more question before we turn to the panel, if there are any. I see a lady in blue. Yes, please.
Thank you. My name is Julian Kaiwanda. I'm from the University of Tourism, Technology and Business Studies. One is a recommendation and the other is a question, but I'll start with the question. Clearly, the pandemic has increased public engagement in science and medicine. But while Melissa represents the private sector, I'm interested to know, or understand at least from the perspective of everybody in the room, because we have academicians and we do have scientists, but especially from RBC, how do we intend to generate new sources of private finance from outside the health sector? Because we realized that during the pandemic, while the entire government came together, but much of the funding was really from the health sector. The other one that is probably up for discussion amongst all of us is that we should increase efforts in creating a broader knowledge sharing platforms because we have learnt a lot during the pandemic and other epidemics, but we need more proof of concepts to be able to start sharing knowledge beyond scientists to include everybody in the room and beyond. Thank you.
Thank you very much. So we'll take those two from Joris and Julien, I believe. So the first question goes to the Director General, the access to data and ways to streamline sort of the large volume of data.
Yes, I think, thank you very much for that question. I think I was expecting that question because I know that there's been some, I think I can say misunderstanding about data. I think at RBC and also in the health sectors, we have data and they are available. But I think also, I think the beginning, in the past, I think there used to be some issues around data. But again, nowadays we have a strong feeling that we need to use our data to really identify those needs and probably also get to collaborate with institutions, higher learning institutions, and also private sectors on how to come up with an idea where, because we know where we're not doing well, if there's no prior dialogue, if there's no space for dialogue, probably there might be some misunderstanding about what is the needs of the government of Rwanda, for example, in terms of these research priorities, and also the institution that is looking for data might also not be able to really very well articulate or match the request for the data, not really duplicating what the Ministry of Health is doing, but also working together to understand very well with the fund that is available, how can we discuss and probably reallocate these funds to where we need to invest. So I think if there's a transparent dialogue in terms of, first of all, we have to identify our needs, but of course also we need also to have people at the Ministry of Health who are really ready to engage in those dialogue and probably come to a common understanding of where we need to first of all do research, and the need of data will come later. But again, when the data is only the one that comes at the beginning of these interactions, probably there might be some misunderstanding. So I think RBC and the Ministry of Health is open to share our needs, to collaborate together, but also to see the involvement of each one in joint use of data. And we have established structure and policies on how to share data. And most of the times, as I said, at the Ministry of Health, we are very busy in implementation. But I think now we are putting some system in place to really make sure that we allocate time for discussion around data, but also how to use those data so that we respond to our really needs instead of responding to the needs that is not really helping our intervention. So if you come with a project which is going to be an answer to the needs or to the areas where we have problems, I think those requests will be welcome, and we'll continue to use this platform and also other platform to work with universities and probably have a strong research team so that we can really use the data for the mutual benefit. I think that is what I can say.
Can I add something?
Yes.
I'm very talkative, but as far as I'm concerned, and I'm not at RBC and I'm not in the ministry, I never get a no to access data. When I have a good protocol for research with a clear objective and saying how it will help the people who are working to collect those data and the subject of the research. I don't know if you get it. And in the developing world, what exists? There is nothing more colonialist as attitude than to go to institution, has the data, triangulate them, do research, and publish in your own. Look at the international way publications are done in the scientific world. We have this number of people from the country where the data are collected, meaning the people who do the work. And we have this number of people publishing about them without them. And those people here, from here to there, consider as the experts. They are just slavers. So I congratulate RBC and the ministry to just tolerate research on Rwandan people that serve the Rwandan. And if you do that, I'm sure you will not get a no. So the question you asked, sir, I don't know you, but I didn't like your question. Data are available, prove that you are useful for the people.
So
thank you.
Thank you. I think that it's stimulating discussions, because as we know, data is a very valuable asset. And, you know, RBC, Ministry of Health, open to working with you. And I think, again, we know we can't do it alone, so very open to collaboration. So there was also a question and a comment from Juliette around funding, which she mentioned, and it was, I think it was around funding in the context of because we're currently in the pandemic, and the funding that has come through to the health sector. I think it was a question about how do we generate more funding. And there was also a comment around the efforts to increase basically the knowledge sharing. Beyond this room, it links to what we're talking about, and basically disseminating and reflecting on this knowledge. So it was an open question. I don't know if anyone wants to jump in on either of those before we turn back for a quick question. So on the side of generating funding, I can't comment, I'm a moderator, but I would, I would have commented that, you know, when you're in the room and you have government and you have private sector and you have academic institutions and you have even individual researchers, what you find is there are opportunities to actually come together. And I know we've had this discussion, whether it's with Professor Binagwaho and some of the other panelists. The funding is there, and it's about sort of, I was going to say, coming together and being able to craft these proposals, to be able to actually highlight, here's a challenge, here's a solution, and here's what we are proposing. That would be my comment. I don't know if any of you want to add something. And then there was a comment or a question around how do we keep increasing our efforts to build knowledge beyond this room of maybe 100 people. How do we go beyond what is being talked about here to everyone, including the population? I think the community sometimes we have to be reminded, or remind ourselves constantly, that the main actually stakeholders in everything that we say is not the government, as much as I work for the government, but it's the community. So any quick, I can welcome one or two comments from the panelists, and then I'll turn back to the audience, if you allow.
Just a quick question. Are there partnership programs available for investment from in Canada? We frequently have programs that are 50% for whatever the cost of a project is. So it's expected that the innovator or the private sector individual who is applying for funding, and sometimes even the academic side, it's expected that they will go find 50%, and there are 50% programs offered by either the province or the federal government. Mm-hmm. I don't know if that program or anything like that sits here.
So we're in the right venue. I don't know if Marie-Chantal, you want to comment. It's our host, NCST, would probably be, yes, be able to comment.
Well, I know that's one way for stimulating, getting people to get the funding that they need to execute projects, and sometimes it's 3, sometimes it's a third, and a third. And those types of programs make sure that the risk is spread out across multiple agencies or individuals, but it also brings the affordability for any single one of the agencies down.
Stand up so they see that you want to talk, because they don't see you want to talk, so they didn't give you the floor.
So Professor David is, yes, go ahead.
At NCST, we have a department which is in charge of the fund. It was founded in 2018. So it's the one which manages the government fund. So we have different projects, and some of the presenters today have presented the project that we found. And I think this is a start, and we are also looking for new strategy to mobilize more and do the collaboration for those kind of founding agency that you are talking about. Also, the universities have research institution where the researchers also apply for the fund outside the country, and there is also a way of managing those kind of funds, and there is also a way of sometimes as you are saying, 50 from the private sector and 50 from the public institution. It depends on which kind of fund you applied for. So, but we are still ongoing. I think it is going. For the moment, in our institution, we give 100% of the fund, and the institution can manage and can take, let's say, 20 for the management, and the research can also show how they use it. But I think people in the room also, they have another way of, they are doing this kind of fund management.
Yep. So, and now the question was for documentation. We have a problem in developing countries is the lack of human resource. So where you work, most of us here overwork. And we don't keep this time for documenting and writing. And also, documenting and writing is not rewarded the same way that in high-income countries. So we work 10 hours a day, not 8, sometimes 15 hours a day. You don't have that period to document the great job you do, and so it is not documented. So I think the strategy now should, for all universities, to let the faculty having a 20% of their time for them. And we should have the same at RBC, because they are doing so much. They document so little. Why? Because they are working 15 hours a day. When there is a crisis there, they are upside down, and they are responsible, they are under stress. They don't have time to sit and write about what they do. The strategy is simple. One good that is so, we say time is money. Time is more than money. Give them the time to document, to strategize, to sit. Isn't it, Doctor, Professor?
I agree.
Time. Because they all know how to write. They have conceived these incredible programs. They have implemented them. They're the best to write about it.
Thank you. I do agree. I do agree on this part. You'll find that to your question, Julienne, I think that's what it takes, right? So rather than we're doing implementation and no documentation, it's documenting along with the partners, because again, the program implementers don't work alone. So I want to turn back to the audience again and see if there are any other comments or reaction to what we heard here from the panelists. I see somebody, yes.
Hello, can you hear me?
Yes.
Okay, my question goes to Professor Binagwaho. I hope she will like my question.
Don't worry, if I don't like the question, it's not your business.
Okay.
It's my task. So
okay.
don't customize your question to what I like.
Thank you very much. Okay. So mine goes to the linkage between academia and the private and the PSF. Professor who has been involved in different policies and also she has been lecturer, she has been involved in academics. So, and she knows the lot of lecturers who are always teaching and then with less hours for doing research and linking with private or private institutions or companies. So I would like to hear from you the advice to lecturers who are always involved in teaching with less hours to be involved with the private companies to do research. And how can you, and then another advice maybe to high learning institutions, how can they increase the cooperation between academia and the industries? And number 3, to lecturers, how can lecturers benefit from this linkage between universities and the companies, maybe regardless to welfare of the lecturers? Thank you very much.
Thank you. So I'm going to start by the last one. How can lecturers, that mean universities, benefit from the link with private sector? I think now all universities in Rwanda have innovation hub. There are also innovation hub out of universities. If universities are not on the front of innovation and discovery, just close your university and go at home. Got it? We need, because we are supposed, we need to be at the front. So now, how to do that? Make yourself indispensable. Make yourself attractive to the private sector. Go and dialogue with the private sector and tell them how they will benefit, because private sector is there for making money. Don't expect something else. They don't have to be kind. They are even not obliged to help you to develop. However, if you show them that what you can bring to them will help them to develop and make money, please go and do it. You can even do more. What I'm trying to do for my university, I try to make it self-sustained. I'm going to create businesses. And I'm going to make those businesses make money for the university. You see it. The boundaries are just in your head. They're not in public life. I can be the vice chancellor and even have my own business. I don't have, but there is no boundaries. If you see also, why do you believe the Silicon Valley is near Stanford, near big universities like that? Because they know where the brain are. Why do you believe those great private sectors, entities are doing competition among students in the last year? It's just because they're going to head onto the best. You see? So us as university need to be on top, educated to make our student and ourselves the best and indispensable. Don't sit and wait to be considered as indispensable. Make people look at you and want to hunt you. I forgot the two other questions. What were they?
I think you sort of responded
Okay.
to them, because
Yeah.
I think my takeaway from this, and I think the question was well received.
And you can ask Noella and Professor Muvunyi, there is even no boundaries between the ministry, RBC, and the medical schools. 20% of their time, I buy it. You know why? Because there is nobody better than them to manage a COVID pandemic on Earth. And they have practically the best people to teach my students on that. So for executive education, we have a contract between MIFOTRA, between Mineduc, between Minisante. 20% of the time they can go and teach the great things they do. Tell me, where is the boundary? Now, 20% of the teachers have also to go and give clinical service to hospitals. It's a win-win situation. Because if the teacher doesn't practice, after 3 years, they are obsolete. You see, we are all interoperable, not only the computers and the software.
Well, we will end on this high note. I will take just a few seconds, if you allow, to go through all the panelists, because we started by reflecting on, as we're ending on this high note, we started by reflecting on the strategic R&D investment, and we've been talking about academia, private sector, and government, and many of the questions and the points raised came back to this interconnectivity, and I think it's one of, I think for me, it was the takeaway. But I want to turn from Elisa.
Conversation is first as a Rwandan person and also as a young conversation is first as a Rwandan person and also as a young African is from what the discussion has been saying here today. Is once you have a vision and a good leadership, anything can happen. I think Zipline is one of the proof that once you know what you want and have an idea and a vision, the technology will always support what a leadership would want to do with the technology. So my takeaway here is thank you for the leadership, thank you for the research and the hard work, and I think from the young people that I work with and the young students that I see coming to Zipline, I definitely think that the exposure to such technology has helped and provided bigger dreams to the next generation. So thank you for everything.
Thank you very much. So Professor David, your takeaways and message to our audience today.
Passion. It's passion. Find that idea, grab it, treat it like a child, and nurture it, watch it grow. That's it. Passion. Because if you have that, you'll take it forever.
Yes, Prof. Muvunyi, we'll turn to you as well. Just reflection to the audience.
Yeah, I think my reflections here is to be that let's be driven by data, and with data we can bring investors, but also we can know if you're doing well in terms of innovations. Thank you very much.
Awesome. And yourself?
Just wake up in the morning and understand that the sky is not the limit, it's the flow. That if a country like this country, that it's still among the bottom for economic capacity, is where we are. Tell me what is the limit? Nowhere. Just we are our own limit. So no boundaries. We have understood that we need to grow more people, to give to the implementers and to academicians more time to document and to think. We have strategies. We have also blah, blah, blah. So let's focus on strategies. But the sky is the flow, not the limit. Not the limit.
I want to thank the panelists today. The keywords that I heard were leadership and vision, passion, data, and the sky is the floor. So I want to turn to thank you, the audience, for making this panel very conversational and very, you really kept us thinking here. And so thank you for this opportunity, and I thank my panelists today. It was high caliber. You can, sense the passion from the academic to the private sector, so it was a good mixture as well as the government. So thank you again, and I'll turn back to you, Marie-Chantal.
Much, Noela. Yeah. I know you had a lot of questions, but the time is not on our side. We still have few things to do, and I would like to recognize the presence of Honorable Minister of Education, Dr. Wamaria Valentine. She's now here with us, and I am going to turn over to our Executive Secretary to welcome her. Thank you.
Thank you, Chantal, and co-chair of Scientific Organizing Committee. Honorable Minister, I would like to welcome you to this audience. And before we welcome you on the podium, allow me to give you a summary of what has happened in these 2 days. Yesterday, we started our conference with welcoming remarks from the chair of the scientific committee, Dr. Marie-Chantal. I, the speaker, also had the opportunity to give welcoming remarks to the participants. Later on, this conference was graced by opening remarks from Honorable Minister of Health, Dr. Ngamije Daniel. And that was the first part of opening remarks. Later on, we were very fortunate that Professor Binagwaho provided a keynote address on management of COVID-19 in Rwanda, but also globally. And we had a couple of presentations, abstracts from the audience, but also some of the presentations were virtual. Later on in the afternoon, we had a couple of presentations. We were also fortunate that we had keynote speeches, notably from Dr. Roger Glass, who is the director of Fagate International Center of the U.S. National Institute of Health, on building resilience to COVID-19 pandemic and other epidemics and potential pandemics for developing countries. We were also fortunate to hear from Stephen Leslie, who is the CEO of Research Nova Scotia in Canada, on investment in R&D, specifically on COVID-19 and other epidemics, and how can developing countries cope up with what developed countries have done, but also what lessons can developed countries learn from developing countries. Today we had very interesting sessions. Today we were fortunate also to have a keynote address by Dr. Mambo Claude, Director General of RBC, who gave us an overview of Rwanda's response to COVID-19 pandemic, but also what has been the African context in terms of responding to COVID-19 pandemic. We also had a keynote address by Professor Winfred Ndifone on how do data inform us as a nation, as a nations, on looking into the future, predicting and monitoring COVID-19 pandemic using pooled analysis, some of the studies they have done in Rwanda. That was a very good presentation as well. Later on, we had several discussions, presentations, and abstracts from various speakers. Later on, we had the keynote address by Dr. David Kelvin, on vaccine manufacture and building resilience and for prevention of COVID-19 and other viruses globally based on vaccination programs. And I believe those were major keynote addresses. Honorable Minister, I want to say that the audience you see here has been very interactive, very interactive. You could even see it from the previous session, because as you came in, we had the panel discussion, which you witnessed by very important people, very informing, very engaging on where we as a country, where we as Africa, and where can we go together in terms of investment in science and technology, in research, in order to build resilience for the country, for Africa, but also for the globe, especially that we have now learned more and more that without being together, we cannot fight pandemics or even epidemics. Honorable Minister, I want to thank this audience, and I think, please, a round of applause, because they have done a wonderful job. Very engaging, a lot of questions, a lot of comments. We want to really thank you very much, and hopefully, if I am allowed, I could have, a vote of thanks later on in the evening. At that juncture, Honorable Minister, allow me to welcome you to the podium to provide your concluding remarks to our conference as we go towards the final touches of the conference. Thank you so much.
Thank you, ES, for giving me the floor. Executive Secretary of the National Council for Science and Technology, distinguished keynote speakers, vice chancellors, rectors, directors of higher learning institutions, distinguished director generals, chief executive officers, executive directors, managing director of respective institutions, distinguished country representatives, country managers, country directors, chief representatives of development partners, distinguished guests, ladies and gentlemen. I would like to express my gratitude to the National Council for Science and Technology, NCST, and all the national stakeholders and partners for their dedication to make this event successful. I'm extremely pleased that this first Rwanda Science, Technology and Innovation Conference, whose theme is leveraging the potential of science and technology to mitigate challenges associated with COVID-19 pandemic in the developing countries, has taken place at a very crucial time. The conference was well attended by various stakeholders, ranging from public officials at policy level, researchers, experts, and young innovators. As we all know, the COVID-19 pandemic that emerged in December 2019 affected the society ranging from health, social, economic, and well-being. On the impact of COVID-19, the impact of COVID-19 was also its effect on human resources development, affecting education system and knowledge creation, and deepening through research. I therefore would like to thank the government of Rwanda through the National Council for Science and Technology for funding 17 research grants to address COVID-19 pandemic in Rwanda. In addition, I would like to thank all national and international scientists and researchers who have implemented studies on COVID-19 pandemic and contributed to important scientific presentations for this conference and beyond. During this conference, we have heard from different perspectives, from rich presentations, keynote speeches, and research findings, and a panel discussion that were filled with insightful content. It is unfortunate that I came at almost at the end, but what I could hear, I believe you've had a good time discussing sciences, research, and all that. I believe that the participants benefited from the exhibitions, poster presentations, and networking opportunities throughout the conference. I'm sincerely grateful to keynote speakers who shared with us insights on the 4 sub-themes for this conference. The pandemic has once more showed that science and technology provide sustainable solutions to mitigate its impacts, not only in developing countries, but in the whole world. This was well presented by different researchers in different ways during this conference, for example, touching on innovative strategies utilizing evidence-based scientific and technological tools to close the gap for COVID-19 related challenges, existing data to leverage the potential for science and technology to mitigate the impact of the COVID-19 pandemic in developing countries, sustainable solutions and strategies to inform future research and capabilities in response to COVID-19. And lastly, they also shared with the audience the strategies and opportunities to find research and development projects in sustainable ways. The COVID-19 pandemic has revealed how globally interdependent the world is and how extreme inequalities in science, technology, and innovation capacity affect productive capacity across countries and regions in an unfavorable manner to humans. It is evident that more research, data, and knowledge are required through collaboration to share the best practices and evidence-based policy decisions to cope with the immediate impacts of the current COVID-19 crisis and go beyond it. Database on science, technology, and innovative programs play a central role in sustainable and resilient recovery from the COVID-19 pandemic. On this note, the government of Rwanda is committed to supporting knowledge transfer and sustainable innovations based on research by continuously making strategic investments in research for national development. Allow me to make a few examples of Rwanda's commitment. The government of Rwanda established the National Research and Innovation Fund, through which research and development is funded, and the Rwanda Innovation Fund to support different innovations that require to be scaled up. As Rwanda envisions to be a regional and continental hub for R&D output and innovation, a lot of efforts is put on broadening R&D collaborations and increasing R&D investments. This is well demonstrated by establishment of several centers of excellence in various sectors at University of Rwanda, and supporting hosting several renowned global universities such as CMU Africa, UGHE, and AIMS, to name few. The 2 days conference has revealed that good research has been done in different areas, especially focusing on the solutions to mitigate the impact of COVID-19 using science and technology. This conference has helped with a scientific review leading to awarding the best researchers of best 4 categories that we will award in a moment. Therefore, I believe that the set goals of this conference have been achieved, and we are looking forward to more conferences like this in the future. I'm certain that you have enjoyed the benefits of this conference, and I hope that in the near future, the participants who attended virtually will be able to come to Rwanda and enjoy the natural breeze of Rwanda, a country of 1,000 hills and smiles. I wish to officially close this conference and look forward to seeing you at the awarding ceremony. Thank you, and God bless you.
Thank you so much, Honorable Minister. We had great time, and I think in 2 years to come, we are going to have another one. We can't end our conference without an entertainment. So we have provided for you something, and I would like to welcome Inayoberana to come through. And thank our audience and participants to make this conference a success. to go to the awarding ceremony party and the dinner, and is right, and our Itorero is going to take us there. So as we make our way, our Itorero is being prepared, and let's wait for them to start.
Karame Rwanda nziza mubyeyi watureze iwacu ni muri Rwanda igihugu cyacu urwemeza abahizugire muri Go!
Oh,